Okay. Welcome to the Pharmacy and Therapeutics Committee meeting. We'll be getting started in about 2 minutes.
And Lita, are we at a quorum yet? I know we're not at 9 o'clock yet, but
We are. Yeah,
okay.
I counted all committee members present.
Oh, okay.
Okay, it's 9 o'clock. I know some people are still logging in, but Ginny, why don't you kick us off?
Great, let's go ahead. So good morning. I'm Virginia or Ginny Bucola, the P&T Committee Chair. We're going to go ahead and convene the P&T Committee meeting, and I'd like to go ahead and welcome everyone who's here and go through our introduction list. After I say your name, if you could just say that you're here, that would be great. So I'm going to start with the P&T Committee members, starting with Alex Park.
Alex Park, committee member, present.
And Diane Schwilke.
Morning, I'm here.
And Jordan Storhaug.
Here.
Nancy Lee.
Here.
And Leah Marcotte.
Here.
And Connie Huynh.
Here.
And now moving on to the Healthcare Authority members, starting with Lita Vasquez.
Here.
And Donna Sullivan.
I'm here.
And Ryan Pistorici. And we'll move on to Luke Dearden.
Here.
Amy Irwin. Moving to Joey Zarate. Moving to Ryan Takatomo. And Marissa Tabile.
Here.
And Chris Chen.
Morning.
And our LNI members, Jamie Mai. Moving to our Magellan Medicaid Administration member, Umang Patel.
Here.
And our DERP presenter today, Curtis Harrod.
Here.
And our managed care organization reps, Jennifer Wang with Molina.
Oh, I'm going to have to unmute them. Hang on just a second.
Sorry to them.
Why don't you just, okay, here's Jennifer. Okay, go ahead.
So
Hi,
Jennifer Wang.
Jennifer's
Okay, and Petra Eckelsdorfer with United.
I'm here.
And Catherine Vu with Community Health Plan. Thanks to everyone.
I'm sorry, I see Catherine is here.
Okay. Thanks to everybody for being here. My apologies for my name. People should send me a personal email if I'm really butchering their last name so I don't continue to do this in our future meetings. But good morning, and I'll hand it back to Lita to go over any meeting logistics.
Great, thank you, Jenny. Okay, so the committee and all presenters have been added to the meeting as organizers. You can mute and unmute yourselves. Please mute yourself when not speaking to limit the background noise. The GoToWebinar limits the numbers of cameras that can be shared at one time. So the presenter will share their webcam while speaking, and then the P&T committee chair, Ginny, will share hers, and up to 5 other committee members can share their webcams during the discussion and motions. You can turn off your webcam when you're not presenting. For stakeholder participation, the chair will read the list of stakeholder names who pre-registered to speak. I will unmute you as she calls your name. Afterwards, the chair will ask if there are any other stakeholders that would like to speak. Use the raise hand icon and I will call on you and unmute you. You'll have 3 minutes to speak. You can also use the question function and I will address your questions during the stakeholder time. The meeting is being recorded, so please state your name every time you speak. All right, thank you.
This is Ginny again. So we're going to get, we have one brief, we have a small P&T committee agenda this morning. We're going to have a CGRP update report from Curtis Herod with DERP, and we'll have stakeholders after that. So I'll turn it over to you, Herod. Thanks.
Thank you very much. I'm happy to be with you here this morning. So today I'll be giving an update, systematic review update on calcitonin gene-related peptide inhibitors, or CGRP, for migraine prevention and treatment and for cluster headache prevention. So we're going to be covering multiple indications today. If you could advance to the next slide. This is just our standard overview.
Oh, Curtis, we can't hear you. Curtis, we cannot hear you.
You can't hear us either.
Hi,
Curtis,
we can't hear you.
we can't hear you.
Curtis, do you want to try calling back in?
All righty, how about now? Okay, sorry about that. I heard one of the panel members talking about technical issues with a broadband, and so I'm at the Center for Evidence-Based Policy because of that issue, so sorry for the audio issue to start the presentation. If I can just table set again, you saw the overview of the presentation. I won't walk through that again. These are just common abbreviations that we'll be talking about through the presentation. They're mainly here to save text later on. So you'll see CGRP inhibitors up there, and then you'll see some epidemiological clinical research terms like absolute risk difference, odds ratios, risk ratios, confidence intervals, things like that. So on slide number 4 here, we're in the background section. We'll start out with migraine headache, and then we'll go into a pattern that you'll see here in a minute. So regarding diagnostic criteria for a migraine headache, headache attacks can occur from 4 hours, so 1/4 of a day, all the way to 3 days or 72 hours, and this can occur with or without aura. So the definition of chronic and episodic migraine has some variation. So chronic is 15 or more headache days per month, and that occurs for at least a 3-month period of time. If we could go back to slide number 4, thank you. And so episodic migraine is fewer than 15 headache days per month. And so that's the discrepancy on the nuance between chronic and episodic migraines. There are preventive treatments, at least before CGRP inhibitors came to the market, and those preventive treatments include antidepressants, anticonvulsants, beta blockers, as well as botulinum toxin or Botox. There are acute treatments beyond just preventive treatments, and those are triptans, dihydroergotamine, nonsteroidal anti-inflammatories or NSAIDs, and anti-nausea drugs. So CGRP is actually a neuropeptide, and it's involved in the pathophysiology of having a migraine headache. Ergo, if you think you can inhibit that, it may prevent it from occurring. So let's move on to slide number 5. And so we're going to transition here from migraine to cluster headache. So cluster headaches just sound awful. Personally, I think we do not have them, but there are multiple headaches occurring within a period of days, weeks, or months. These are called cluster periods. Symptoms of this are very severe. So severe pain, which is usually unilateral and located around the eye, tearing and runny nose and sweating will result from that. And so there are also episodic and chronic cluster headaches, first with episodic. So with at least 2 clusters, this can range from a week all the way to 1 year in time, so quite lengthy. These are separated by pain-free remission of 3 months or longer, and that makes it episodic. Chronic is basically that, but lack of sustained remission between clusters. Similar to migraines, we have acute treatments, simple oxygen, or triptans, lidocaine, and ergots. Preventive treatments include verapamil, steroids, ergots, paramate, lithium, and nerve blocks. So the etiology of a cluster headache is a bit not as well known around in relative to a migraine. So CGRP is believed to be a part of the pathophysiology in hopes that if it's inhibited would prevent a cluster headache. Let's go on to slide number 6, please. So the figure in front of you has 3 columns, and I'll walk you through each one. So we'll start with the monoclonal antibody targeting the CGRP receptor. So that's targeting the receptor, that's oronemab, subcutaneous injection. This is shaded blue to indicate that the FDA has only approved this treatment for migraine prevention. The middle column is monoclonal antibodies targeting the CGRP ligand. So the previous oronemab targeted the receptor. These are going to target the CGRP ligand. So that's eftanizumab, which is an intravenous infusion, and that was put on the market in February of 2020. So it's the most recent infusion, basically, of the CGRP. We'll get to the orals here in a second. And then fremunizumab, which is subcutaneous injection. Both of these are only approved for migraine prevention. Then we get into galcanezumab, which is a subcutaneous injection, and this is approved for migraine and cluster headaches. So cluster headache was added recently as an indication and is captured for the first time within this report. Then we have small molecule inhibitors. So these are antagonists of the CGRP, in which we have rimegepant, which is an oral agent, and then ubrogepant, which is also an oral agent. Rimegepant was approved, if I'm not mistaken, in December of 2019, where ubrogepant was approved in February of 2020. So again, these are fairly recent and encompassed in this report for the first time. And these 2 oral agents are only approved for acute migraine treatment. So there'll be different outcomes based on these different indications, and we'll talk about those in the findings section. We go on to slide number 7. So this is just walking you through the difference between the 2018 systematic review, which some of you also heard and it was presented to Washington. And the 2018 systematic review just included those 4 CGRP inhibitors, whether they're IV or subcutaneous, and that's eftanizumab, oronemab, fremunizumab, and galcanezumab. And they targeted one indication, that's migraine prevention. So this update that I'll be presenting to you today is an expanded scope. And so we have 2 additional drugs, that's rimegepant and ibrogepant, the oral agents, and then additional indications of acute migraine treatment and cluster headache prevention. Please go on slide number 8. Now I'll walk you through the PICOs for the report, and some of which was just covered. But for adults, we'll be looking for individuals who suffer from episodic chronic migraine, chronic cluster headache, as well as acute migraine headache. The intervention will be those CGRP inhibitors that we just talked about within the figure. And our comparators include our placebo and sham-controlled trials, as well as other CGRP inhibitors being compared to each other, or other pharmacological agents like triptans, for instance. Go on to slide number 9, please. So for outcomes, we have a few here. So migraine events, pain relief. And then we get into more patient-important outcomes, such as quality of life, functionality, and disability. Use of rescue medications is an outcome. We'll be talking about that in the findings. Number of ER visits or primary care visits, and then our suite of adverse events, which are common within our DUR reports. For study designs, we included randomized trials, as well as prospective observational cohort studies, but those were for only harms. So only harms were included for observational studies, at least that's all that we looked for. So if we go to slide number 10, I believe we are on now. So we have 3 key questions. First, what is the effectiveness of CGRP inhibitors? Second, what are the harms? So the first will look around efficacy and harms, first 2. And then our third key question is subgroup differences. So are these performing differently by gender, for instance, or by age? We explored that, but of course we're limited to what's available in the literature. So if we could go on to slide number 11. And then number 12. So we are in the methods section, just briefly here. We conducted a comprehensive literature search indicated by a systematic review. So we used PubMed, Embase, Cochrane Library, and we searched those databases from date of inception of that database up to October 31st, 2019. At that point, we conducted active surveillance to March 31st. So what the takeaway should be here is that the report is up to date to basically April 1st of this year. So if a study has been published since April to this day, it will not be encompassed in today's presentation. For once we have identified the eligible studies, we did individual level study methodological quality assessments, and I'll walk through that in the next slide. But we also used OpenEpi, which is a software program to calculate absolute risk differences, risk ratios, and confidence intervals. And then we used GRADE to assess the overall quality of the evidence for an individual outcome, and I'll also walk through specifics on that real quick. So if we could go to slide number 13. This slide highlights our 3 buckets for methodological quality. And so we have good, fair, and poor. Just briefly, a good methodological quality study has transparent methods that are appropriate given the study design and context and have limited to no conflicts of interest. A fair methodological quality study may have incomplete information regarding their methods, so you may not be able to discern one thing or another, some additional small biases, as well as meaningful conflicts of interest. A poor methodological quality study has clear flaws that will introduce significant bias indicated by a poor rating. That can be significant imbalances between baseline characteristics between groups, no allocation concealment, substantial conflicts of interest, etc. So go to slide number 14. So this is the overview of grades, so quality of evidence ratings. We had 3 buckets for our ratings with the quality assessment for a study. So that's at the individual study level, where grade is at the outcome level. So we have 4 levels: high, moderate, low, and very low. At the top of your screen, you'll see our outcomes that we assessed using the grade approach. That's migraine and headache days per month, pain relief, functional outcomes, quality of life, and then serious adverse events and discontinuations due to adverse events. So when we have, let's say, 3 or 4 randomized controlled trials, we'll start at high because those are randomized trials, and that's where they start at in the grade rating. And then we can downgrade from there. So for instance, if those 4 trials have a smattering of effects, a couple said it's significantly different, a couple said they weren't significantly different, or even in the opposite direction, we would have a thing that we call inconsistency and downgrade 1 level from high to moderate. If there's substantial risks of bias within those studies, we may go from moderate to low. So we downgrade based on those issues and a few others I won't walk through today, where cohort studies start at low and you can go down or you can go up. So if there's a dose response, such as the milligrams of the medication increasing and the effect increasing, we're more confident that that is the intervention or exposure, and as a result, we may go from low to moderate. If there's biases in those cohort studies, let's say they didn't adjust for confounding factors, we go from low to very low. And very low is our basement. We cannot go below that, and high is our ceiling. We can't go above that. So I'll walk through those as well as give some interpretation when we talk about high, moderate, low, and very low within our findings. So we can go to slide number 15. And then 16. So we're going to get into our published studies, a little bit of an overview here. So this is our literature flow diagram, again, connected to a previous report. I want to draw your attention immediately to the green box, and we'll spend our time talking about that today. So overall, we conducted a narrative synthesis, so you will not see a meta-analysis. We just did a narrative synthesis, not a quantitative synthesis. There are 27 eligible randomized controlled trials included in our report. 32 publications were connected to that. So there is a one-to-many issue here, as is common in today's literature base. And so you can see the previous report or systematic review, again in 2018, there are 13 RCTs and 14 publications. So the body of evidence has doubled within 2 years. Some of that is because we expanded the indications and there's new medications approved like those oral agents. So let's go on to slide 17, please. So we have 27 randomized controlled trials, as I mentioned, 13 of which are from our previous review, 14 of which are new for this review. All 27 were placebo-controlled trials. So there are no head-to-head studies. I will say, although I don't cover it today, topiramate is an active comparator in one upcoming randomized controlled trial, but that's not expected to be published for a little while still. But there is a head-to-head study registered in clinicaltrials.gov, and that would be the first one for this body of evidence. So of the 27, there are 26 fair methodological quality studies, largely rated that because of the substantial conflicts of interest within these studies. So sponsorship was by the manufacturer. They sometimes helped with authorship or study design. The authors were paid by the manufacturers to write these reports. So those are all conflicts of interest that we're observing here, and a large part of why these are fair methodological quality. There's one poor methodological quality study of the 27. Now, based on the indications, we have one cluster headache prevention study, 13 episodic migraine prevention studies, 6 chronic migraine prevention, and then 7 acute migraine treatments. So those are the Ubrogepant and Rimegepant studies. For key questions, so key questions 1 and 2, efficacy and harms, just as a reminder, we have 23 studies that will capture those outcomes, so efficacy and harms. Key question number 2, just as harms, we have one study that only analyzed harms, and then conveniently for all 3 key questions, we have 3 studies. So the third key question, as a reminder, is based on subgroups, so we have 3 studies addressing that. So we can go to slide 18. So this is just an overview of commonly reported outcomes within the literature and what we'll be talking about today. You'll hear these frequently, so get ready. Change in days per month with regard to migraine was a very common outcome. Another metric, just a little bit of a twist on that, is the proportion of reduction of at least 50% or greater in number of monthly migraine days. So if they had the population that had at least 50% or higher of those, they would qualify as that outcome. And one study went ahead and raised the bar a little bit and went to 75%, but the more common outcome is 50% or more in the number of monthly migraine days. And then we get into functionality as well as quality of life measures. So our HIT-6 headache impact test, 6 items indicated by the HIT-6. And then we have MIDAS, which is the migraine disability assessment, the MPFID, which is the migraine physical function impact diary, MSQL is the migraine specific quality of life questionnaire. For our acute treatments, again, these are Ubrogepant and Rimegepant. They have outcomes of freedom from pain 2 hours post-dose, so a very quick follow-up period for outcomes, hence the acute migraine treatment. And so then freedom from most bothersome symptom, which may be pain in this case, but it is the most bothersome symptom according to the participants in the study, 2 hours post-dose. So a couple of freedom-related outcomes for those oral agents. And last, we have our cluster headache prevention. So these are attacks per week. And so you saw the monthly for migraines, and then a cluster headache, we have attacks per week. So we can go to the next slide on 19. So this is going to start within our key questions. So we're going to start with key question 1. We're going to start with chronic migraine. prevention, and then move into cluster, and then acute is just going to be the pattern that we'll talk about today. So on slide 20 here, we have ectinizumab versus placebo, one randomized controlled trial we identified with 665 participants, and this will be a theme. So findings are reported at 12 weeks, and we have a grade rating of moderate. So that translates to we are fairly confident in this association. An additional study may change our mind slightly, but not substantially, where low and very low will basically say that we're very uncertain in these findings, and high is essentially saying that any additional studies done would not change our mind. So here we're at moderate, so we have moderate quality of evidence for clinical improvements. And as I mentioned, some studies did the 75% reduction instead of 50, so this is one, 75% or more reduction in number of migraine days per month. The placebo group had 24% of participants report that. So 1 in 4 in the placebo group reported a greater than 75% reduction in number of migraine days per month, where the intervention groups, 100 milligram and 300 milligrams, so we have 2 doses for ectinizumab, 37%, 38% respectively, and those one was significantly different. That's the 300 milligram as indicated by a p-value of less than 0.05, where the other 100 milligram was marginally significantly different, but not, and that's a 0.07 p-value. Now, we also observed significantly larger improvements for both the 100 milligram and 300 milligram dose in change in mean headache days per month and a 50% reduction in headache days per month. So they also did do the 50% measure, which you'll see consistently throughout. Overall, we see significant improvements, specifically around that 300 milligram dose. So functioning, we see a change in mean HIT6, which is larger in the 300 milligram dose, but not different for the 100 milligram dose. So we see a trend here where 300 milligrams seems to be more efficacious than the 100 milligram. And again, this is all relative to a placebo, to put that in context again. We can go to slide 21. So moving on from ectinizumab, we're going to get into erenumab. So we have one randomized trial, 667 individuals. Findings are reported at 12 weeks. And the clinical improvement outcome has a moderate quality of evidence rating. And so the change in mean monthly headache days for the 70 milligram and 140 milligram dose was actually the same. So a reduction of 2.5 days per month versus a placebo. And this was statistically significant. And then we saw significantly larger improvements for acute migraine medication use, so the rescue therapies, and then a 50% reduction in number of migraine days per month for both the 70 milligram and 140 milligram doses. For functionality, we have a grade rating of moderate again, and for the 70 milligram and 140 milligram doses, we saw significantly larger improvements as measured by multiple things, so HIT6, MIDAS, and MSQL, so several benefits there. We can go to slide 22. So fremonizumab is next. We have 3 randomized controlled trials with a little over 2,200 participants. Findings are reported at 12 weeks. Sorry if I sound like a broken record, but that is the gist of it today. So clinical improvement was, again, moderate quality of evidence, and there's significantly larger improvements in migraine days per month. This ranged across the 3 trials from 1.7 to 3.5 days across doses, again, and studies. There's significantly larger improvements on all secondary efficacy outcomes across the doses and studies within these 3. Now, for functionality, only 2 of the 3 trials measured functionality. This accounted for close to 2,000 participants. You can see there is a smaller third study, which had a little bit over 200 participants. So they did not measure functionality here, but we do have 2 randomized controlled trials and do have a grade rating of moderate, again, with significantly larger improvements as measured by the MIDAS with fremonizumab versus placebo. So we can go to slide 23. Galcanezumab is our last one on the docket for chronic migraine prevention, and that's one randomized controlled trial with over 1,100 participants. Findings were reported at 12 weeks with clinical improvement grade rating of moderate. And so we see significant reductions again in migraine days per month. So 2.1 mean, that's a reduction, 2.1 on the 120 milligram dose and 1.9 on the 240 milligram dose. So here we don't see necessarily like a dose response where the 120 is comparable to the 240. There's significantly larger improvements on nearly all secondary efficacy outcomes observed, and this encompasses both a rescue medication use as well as that 50% reduction in migraine days. For functionality, we have a grade rating of moderate, and that's a significant improvement observed on the MSQL for both the 120 and 240 milligrams at 12 weeks. And so this again is galcanezumab versus placebo. So if we can go to slide 24. This is a wrap-up slide just covering what we talked about, and you can see there's a lot of homogeneity within our findings. And this is indicated basically because the studies were designed quite comparably, which is sometimes nice to have for a systematic review, to where you have the same outcome, same timeline, same follow-up, and it makes a synthesis much easier. So just to digest this really quickly, eptinezumab and galcanezumab are new to this update. And overall, across these four, we have moderate quality of evidence, and all of which favor the CGRP inhibitor versus the placebo. Again, the placebo is the comparator in this case. So we go to slide 25. So episodic migraine prevention will be our next indication tackled, and let's go to slide 26 to start with those. So for episodic migraine, eptinezumab versus placebo was studied in 2 randomized trials with close to 1,100 participants. Findings were reported at 12 weeks. So for clinical improvement, we have 2 randomized trials with a moderate quality of evidence rating. We saw significantly larger improvements in migraine days per month in the larger of the 2 studies. So there's one study that was much larger, and they observed a 0.7 days reduction for the 100 milligram dose and 1.1 days for the 300 milligram dose. So you'll notice that these are a little bit smaller in some cases on the effect size on reduction in days. And again, just focusing on the fact that we're looking at migraine prevention, which episodic migraine prevention, which is 15 or fewer days in a month, where chronic is 15 or more, sustained over a 3-month period. So by default, you may see some smaller numbers in episodic versus chronic. So a significantly larger proportion with 50% reduction in monthly migraine days were again observed in larger 2 studies, with 50% achieving that in 100 milligrams and 56 with the 300 milligram dose. But again, over 1/3 of the population studied within the placebo group did have that outcome, did achieve a 50% reduction. So over 1/3 of the population achieved that. Other studies were not, and that's the other studies, singular, were not powered, so they did not have statistical power, large enough sample size for efficacy outcomes, and no significant difference was observed in the days per month between 5 to 8 weeks. For functionality, we have only 1 randomized trial that assessed functionality, and it received a grade rating of low. There is no significant differences in mean change of the HIT-6 within eptinezumab versus a placebo. So if we go to slide 27. So now we're on erenumab versus placebo. We have 5 randomized controlled trials making up over 2,500 participants, and a little bit of a shift here. So we have findings at 12 to 24 weeks. So we went up to 24 weeks within this body of evidence, again, erenumab for episodic migraine. For clinical improvements, we have a grade rating of moderate again, with significantly larger decreases in monthly migraine days. This ranged across the 5 RCTs from a reduction of 1 day to 2.3 days for the 70 milligram dose and 1.6 to 1.9 for the 140 milligram dose. So again, you see overlap in the effect based on dose, so no indication that a higher dose is more efficacious. We saw significantly larger proportions with 50% reduction in monthly migraine days in the erenumab group versus placebo, as well as rescue medication use. For functionality, we had 4 of the RCTs measure this out of the 5 of the body of evidence with a grade rating of moderate. We observed significantly larger improvements on various outcomes, and that's HIT-6 and PFID and MIDAS. So we go on to slide 28. Now we're back to 12 weeks. So fremunezumab versus placebo, 2 randomized trials, close to 1,200 participants. Clinical improvement received a grade rating of moderate, and this translates to significantly larger reduction in migraine days per month. This ranged across the 2 RCTs from 1.3 to 2.8. Technically, that's not much of a range, but it's 1.3 and it's 2.8, given it's just the 2. But then we do have the dosages to account for in there too. So we have significantly larger reductions in acute medication use or rescue therapy, as well as symptoms being reported, and a greater proportion of 50% or more in monthly migraine days within fremunezumab versus placebo. So for functionality, we have two randomized trials, and they both assessed it here. So we have a grade rating of moderate with significantly larger improvements in the MIDAS score for all doses across studies. We can go to slide 29. So episodic migraine prevention again, galcanezumab versus placebo, 4 randomized trials constituting close to 2,300 participants, and we have follow-up at 12 to 24 weeks here as well. So clinical improvement grade rating of moderate, we saw significantly larger reductions in monthly migraine days. This ranged from 0.9 to 2 days across doses and studies. We also saw a significantly larger proportion, again, galcanezumab versus placebo, reporting at least a 50% reduction in monthly migraine days. We also saw significantly larger use of rescue medications in galcanezumab versus placebo, and these range from 1.6 to 1.8 days, which I think is an error. I don't think we should be having that. I think this is more of a metric of times of use. Sorry for that. So functionality, we have a grade rating of moderate, and 4 RCTs did capture that with large improvements in galcanezumab versus placebo with MIDAS, MSQL, and HIT6. Though all measures were reported by studies, and some findings were not significantly different. So some of these did not hit the statistical significance of 0.05 reduction for galcanezumab versus a placebo. So we go to slide number 30. This is just a wrap up. Unlike the previous wrap up, we do have some difference here. Eptinezumab, which was again approved in February of 2020, was new to this update, and for migraine days per month, as well as the reduction 50% or more in migraine days per month, we see a moderate quality of evidence rating, where the HIT6 was a grade rating of low, so a little bit lower in quality of evidence, as well as we observed no difference with eptinezumab. All other outcomes got moderate ratings and favoring the CGRP versus the placebo. So we can go on to slide 31 now. We're going to dive into acute migraine treatment. So slide number 32, please. So rimegepant is the first one up. We have 3 randomized controlled trials with over 3,500 participants. Again, rimegepant is being compared to a placebo. And as also a reminder, we have findings at 2 hours post-dose for acute migraine treatment studies. So clinical improvement is again our outcome. Grade rating of moderate. We saw significantly larger proportion of participants with freedom from pain with an absolute risk difference ranging from 7.6 to 16.2 percentage points, and that's in rimegepant versus placebo. We also saw a significantly larger proportion of individuals with freedom from that most bothersome symptom to the individual, which again is self-reported, in the 2 randomized controlled trials that assessed that of the 3. For functionality, we have 2 randomized controlled trials with a grade rating of moderate. We see significantly larger proportions with the ability to function normally in rimegepant versus placebo. So if we can go to slide 33. We're talking about rimegepant now. We have 3 randomized trials with close to 3,800 participants, again compared to a placebo, and findings are at 2 hours post-dose. For clinical improvement, we have 3 randomized trials, grade rating of moderate. We see significantly larger proportions of individuals with freedom from pain. This has an absolute risk difference ranging from 7.4 to 16.6 percentage points. So that overlaps quite nicely with the previous findings on rimegepant. Again, we don't have head-to-head studies, so sometimes our eyes have to go across studies in that manner. We have significantly larger proportions of individuals with freedom from their most bothersome symptom in 2 randomized controlled trials of the 3. For functionality, only 1 of the 3 RCTs measured this. We have a grade rating of moderate with significantly larger proportions of individuals reporting ability to function normally within 2 hours post-dose. Those are odds ratios of 1.7 and 1.9 for 50 milligrams and 100 milligrams respectively, and those are significantly different. So we go to slide 34. So this is just a wrap up. Both are new because they're approved after the original report. So for rimegepant versus placebo, as well as rimegepant versus placebo, we have moderate quality of evidence across their outcomes, and both favor the oral agent versus a placebo. We go to slide 35. Now we're going to get into cluster headache prevention, and starting on slide 36, we'll talk about some of our findings. So we have galcanezumab versus placebo, And this is a randomized trial of 106 participants, so a pretty small randomized trial. Galcanezumab, again, is the only CGRP inhibitor with the cluster headache prevention indication. I captured that in the figure at the beginning of the presentation. The findings up to 8 weeks are reported for cluster headache prevention connected to galcanezumab treatment. So for clinical improvements, we have a grade rating of low, so a little bit reduced confidence here, and let me explain why. So we have a mean change in frequency of attacks per week at week number 3. This resulted in a 3.5 reduction. You can see our confidence interval indicates statistical significance because we do not have 0 within the confidence interval. However, when we translate the findings to week 8, we see an actual increase in 1.3 on average. This was not statistically significant because we do have 0 within our confidence interval, but it is also a worrisome finding. It is a small trial. I do want to caveat that. Maybe an additional larger study may find something different. But at 3 weeks, we have a 3.5 mean reduction in attacks per week relative to a placebo. And then at 8 weeks, we actually see an increase in galcanezumab versus placebo. It's not significant, but it's not a direction that's probably desired. And then for functionality, none were reported as far as outcomes are concerned for this one small trial. So if we go to slide 37. This is just wrapping up. Again, this is the only approved indication for cluster headache, and we see low quality of evidence for both outcomes that were assessed for galcanezumab versus placebo. And again, favorable outcomes early on, but those did not hold a longer-term follow-up, and it's hard to say longer-term follow-up when we're talking 8 weeks, given that cluster headaches can last for a year in some cases. So basically, we need more evidence, longer-term follow-up studies, and larger samples to better understand this drug. So on slide 38, we're going to now dive into adverse events or harms for CGRP inhibitors. So this is key question number 2, and on slide 39, we'll begin our findings there. So this is just an overview set up for the body of evidence for chronic migraine prevention. We have 6 randomized controlled trials with over 3,500 participants. So we have 1 RCT with eptinezumab, 1 with irinimab, 3 with fremonezumab, and 1 with galcanezumab, all again versus a placebo. And I will stop and note here that we look for observational or cohort studies for harms only, and unfortunately did not identify any within our systematic review update. So we are just relying on trials to talk about harms and adverse events. As most of you likely know, trials are not usually powered, number 1, for adverse events, and then number 2, typically don't have the follow-up necessary to determine long-term consequences. And so for our findings, we have serious adverse events, grade rating of very low, low for fremonezumab because they have the 3 RCTs, so a larger sample. Overall, rare events cannot be necessarily established because of the smaller sample, smaller follow-up time, and infrequency of the outcomes occurring. So we have very low confidence in 3 of the 4, and that translates to no confidence in the findings. And in fact, a new study would dramatically change our findings, is the translation of a very low rating. For discontinuation due to adverse events, we have again a grade rating of very low and low for fremonezumab. And unfortunately, relationships cannot be determined because of the rare events that are occurring here with discontinuation due to adverse events. So if we go to slide number 40. Now we'll talk about episodic migraine. So we talked about chronic on the previous. We'll talk about episodic now. 13 randomized controlled trials addressed adverse events or harms with close to 7,400 participants. 2 RCTs were on eptinezumab, 5 were on irinimab, 2 were on fremonezumab, 4 were on galcanezumab. For our findings, again, serious adverse events were rare events, and a relationship could not be established with a grade rating of very low. We also had discontinuation due to adverse events captured within these 13 RCTs, a grade rating of very low because rare events were quite rare, and a relationship could not be determined with discontinuation due to adverse events. So we go to slide number 41. Now we're going to talk about acute migraine treatment. Again, rimegepant and brogepant. We have 7 RCTs, over 8,500 participants. 3 RCTs analyzed rimegepant, 4 analyzed brogepant. And the same story here with serious adverse events. We have a grade rating of very low. These were infrequent within the studies, and a relationship could not be determined because of that. So if we go to slide 42. So cluster headache prevention, talking about harms here. We had one comparing galcanezumab and placebo, and that's that one small trial that we saw some different findings versus the rest of the body of evidence. So a sample of 106 individuals, serious adverse events, very low rating, no events were observed, relationships cannot be determined, hence because there's no events within the small 106 sample trial. Discontinuation due to adverse events is the same story, very low rating. Rare events did, so there were some discontinuations, but not enough to have a meaningful relationship be determined. So if we go to slide 43. Now we're going to get into key question number 3, and that's around subgroup differences, and this can be both for efficacy and adverse events. The spoiler alert is that there's not a lot of evidence out there on subgroups, so let's go on to slide 44 and address that. So we, ultimately, a few studies reported them as far as subgroups are concerned. Fremonizumab, again, those 3 studies that we talked about previously for migraine prevention, reported similar efficacy in participants not taking concomitant preventive medications compared to the full study population. So that's the one subgroup analysis that was basically done within these trials. So not a broad or deep analysis here within subgroups, and more evidence is needed to better understand this. So we go to slide 45. We're going to start with our discussion now. On slide 46, we'll get into our details. So we do have some caveats here as far as limitations of the body of literature, as well as our review. So we captured no head-to-head studies. So one CGRP versus another was not in there. A CGRP versus another treatment like a triptan is also not in our report because we could not find them. There is, again, the one registered ongoing study of topiramate versus CGRP inhibitor, and that could be forthcoming. All of the included studies were conflicted. So there's sponsorship of the studies by the manufacturers. Some of you may be unaware, but there's a growing body of evidence within Cochrane, there's a Cochrane systematic review, indicating that sponsorship of studies significantly biases the study in which they're more likely to report a positive effect than a study that is not sponsored by a manufacturer. So that's why I'm talking about that today, is we have a growing body of evidence indicating that sponsorship of studies may lead to substantial conflicts with different findings. We also have most of the studies, the prevention studies, only have 12 weeks duration, and that's a pretty small period of time for generally a condition that affects an individual for their life. And so longer follow-up is needed for these studies. The acute treatment studies only assess an individual migraine attack, so they didn't look at a subsequent event, only that single one, the initial acute attack within the studies. Nearly all prevention studies required a run-in phase, and that run-in phase consisted of an electronic headache diary. So as we can probably assume, not everyone will adhere to that in the real-world setting. So what happened in those trials is that if the patient did not adhere to it, they were not enrolled in the active phase of the trial. So the run-in phase, weeded those potentially out, limiting generalizability of findings. And then most of the excluded patients had clinically significant psychiatric or medical conditions. As well, pregnancy was not studied in any of these, and so we don't know about the efficacy of CGRP in pregnancy, as well as within individuals with psychiatric or other medical conditions. So in general, the populations were fairly healthy that were studied, so it is, again, a note about generalizability. So if you go to slide 47. Continuing on with our limitations here, women compared to men do have a higher frequency of migraines, so they report them more frequently, as well as suffer from migraines more frequently. So it makes sense that the study populations analyze more women than men. However, some of the studies looked at only about 90% of women. As a result, only 10% of men were studied. So that limits the generalizability of the findings to men with migraines. And then furthermore, most of the studies did actually not report race or ethnicity, so we couldn't discern the demographics or patient characteristics within these studies as well because of that. So again, a note about generalizability. Few studies, as indicated by our key question number 3, addressed subgroup differences, and no studies reported on patient important outcomes such as employment or healthcare utilization. And then lastly, this is a note about our review. So we did not request dossiers from the manufacturers. So as a result, we did not explore conference abstracts or press releases or oral presentations at conferences or posters. So those were not included in our analysis, though the body of evidence is growing, as you saw, based on published literature that is peer-reviewed. And we only looked at studies that were published in English. So those are some limitations to our systematic review. So we can go to slide 48. So let's start with migraine prevention as far as conclusions are concerned here. So relative to a placebo, we see etinizumab, ranibizumab, franizumab, and galcanezumab were more efficacious, again, relative to a placebo with moderate quality of evidence. Chronic migraine days range from 1.8 to 3.5 fewer within those CGRP inhibitors versus placebo. For episodic, slightly lower range, but again, there's some overlap here. And just a reminder for the third time, I think here, so episodic migraine 15 or fewer per day, or chronic is 15 or more, per month. That'd be terrible if that was per day. So 15 or fewer per month, where chronic is 15 or more within that month. So you'll see some natural variation by those indications, but yet we have overlap and reduction in days within the month. So serious adverse events and discontinuation due to adverse events, as we talked about, were infrequent, they were rare, and as a result, relationships could not be determined, and that's a very low quality of evidence ratings for those. So we can go to slide 49. We'll transition from migraine prevention to acute migraine treatment now. Again, relative to placebo, rimegepant and brogepant were more efficacious with a moderate quality of evidence rating. And the proportion achieved freedom from pain at least 2 hours post-dose ranged from 6.4 to 16.6 percentage points higher for active doses relative to a placebo. And then for serious adverse events, same story as the other CGRP inhibitors that are not oral. We see no relationship that can be determined because of the rarity of the event. As a result, we have very low quality of evidence. So going on to slide 50. We have cluster headache prevention conclusion. So galcanezumab was more efficacious in the short term, so that 1 to 3 week range, and we gave a grade rating of low. But again, at the 8-week period of time, there was no significant difference. And so this is unclear because the trial was 106 participants, so a small trial, there may be power issues. It was in the non-desired direction in which a placebo was actually being favored at 8 weeks. So basically, we just need more evidence in this area for cluster headache prevention, specifically to galcanezumab, which has the FDA-approved indication. There are no serious adverse events occurred, and discontinuation due to AEs or adverse events were rare, and as a result, no relationship could be determined with very low quality of evidence rating. Let's go to slide 51. So this is our last context slide, or information slide here before I open it up to questions. So there's no direct head-to-head evidence, which we've talked about. One way to potentially get around that is you can look at a network meta-analysis which offers indirect comparisons. We didn't talk about those in our findings today. They are in the discussion section of the report, and they do address migraine prevention and acute migraine treatment. And so take a look at those. If you'd like, I will tell you just very briefly about this network meta-analyses. Again, indirect comparisons which can be flawed. We don't see substantial differences indicating that one CGRP inhibitor is better than another, or another migraine treatment that's not a CGRP inhibitor performing better than a CGRP inhibitor. So essentially, there's comparable efficacy across these different treatments is what that network meta-analysis found. And so for preventive therapy, state Medicaid administrators might consider route of therapy as well as additional costs. So for instance, etinizumab is intravenous infusion. The others are subcutaneous injections. And so these may be relevant things to consider as you walk through this body of literature, given the fact that there's comparability in a lot of our findings. So I will wrap up there, and I'm happy to take any questions.
Thanks a lot, Curtis. Are there any questions from the committee?
It's Alex Park. I have 3 questions, if I might. Thank you, Curtis. Wonderfully detailed and thorough presentation. And it looks like, compared to our last review, we have more evidence for eptinizumab. So would you say it's safe to elevate that, to include that in the motion as being equally safe and efficacious with the other 3 drugs?
So I think that's something for the committee to decide. What I will say is that eptinizumab, at the last time we talked about this report, was not approved by the FDA, and so the committee may have considered that different because of that rationale. And so I think more discussion should go on with that. They did have comparable findings relative to the other CGRP inhibitors for the most part within our evidence base.
Okay. And I don't know if it was a typo or if it was a good point favoring eptinizumab, but they were looking at a 75% reduction versus many of the other studies doing a 50%. Is that right?
Yeah, so that's not a typo. They did look at that. It was the one study who kind of raised the bar a little bit from 50 to 75, and they did report 50% as well. So they did find significant differences in that 75% reduction.
Okay, that's good to know. I think that would help the committee in making that decision. And then my next question is just educational. You know, looking at the accessory report that you sent out, the adverse event rate on some of these studies, they can go 40, 50, 60%, which sounds really high to me. But then the serious adverse event rates is quite low, usually single digits. So what kind of adverse events are they seeing? And is that pretty typical in this literature?
Yeah, it is really typical in the literature. Adverse events are basically anything that's reported by a patient. So in most cases is injection site pain for the subcutaneous injection, which, as you know, is common within any type of literature looking at an injectable. For serious adverse events, the one that was reported, again, rarely, were liver enzyme. And so there's some potential concern around liver functionality. They weren't different between, and I want to be clear about that for serious adverse events, they weren't different between the CGRP versus the placebo, but these are randomized trials. It is a short-term follow-up, and they're not necessarily powered to detect a difference there. So I do want to put those caveats, as that might be something to look forward to in an observational study with a larger cohort.
Okay, thanks. Last question, the oral agents, they were only assessed for acute treatment, not for prevention?
That's correct.
Okay, thank you.
Yeah, thank you.
Any other questions from the committee?
Hi, this is Leah Martha. I have one question. Do you know of any comparative effectiveness non-industry trials or non-industry sponsored trials that are ongoing right now with this medication?
Yeah, so I would have to, let me look at the report real quick. There is the topiramate head-to-head study, so I'll pull that up. That is a registered trial. I will note there was a June 2020 completion date, but as everyone knows, June is a different month than we ever thought it was going to be. So there might be some delays in that trial of it being completed. We were pretty excited to see that comparative study at least being registered because, as we talked about, all the included studies today are strictly placebo-controlled trials. And so let me just pause for a second. So it is erinimab versus topiramate, so 70 milligrams and 140 milligrams of erinimab and 50 to 100 of topiramate. 770 participants are enrolled in this trial, and they're looking at episodic migraine.
Great, and so that's looking at preventive.
What's that?
That's looking at preventive, presumably.
Yep, episodic. Yep, correct.
Okay, this is Ginny again, just chiming in to make sure everybody's got their questions answered. Yeah, okay. Curtis, thanks again very much.
Thank you.
We'll move on to stakeholder input. We have 3 stakeholders, Chelsea LaRue, with Biohaven Pharmaceuticals, then Tim Wardell with AbbVie, and then Carrie Johnson, PharmD with Amgen. If there are any other stakeholders I haven't mentioned, please go ahead and just raise your hand so that we're aware that you're here. Chelsea LaRue, are you ready to go?
Hi there, are you able to hear me okay?
Yes, we are, and you have 3 minutes for your time. Thank you.
Okay, thank you. Good morning, my name is Chelsea LaRue and I'm from the Medical Affairs Department at Biohaven Pharmaceuticals. I appreciate the opportunity to present additional supportive information regarding Nurtec ODT or rimegepant, indicated for the acute treatment of migraine with or without aura in adults. Nurtec ODT is available in a 75 milligram orally disintegrating tablet formulation that dissolves rapidly within seconds without the need for water and is the only oral CGRP antagonist with a long half-life of 11 hours. Nurtec represents a novel mechanism of action that directly targets the underlying pathophysiology of migraine, treats migraine without the vasoconstrictive effects of triptans, and is not associated with addiction potential or medication overuse headache. A migraine treatment is considered suboptimal if the patient experiences persistence or recurrence of their headache after taking their medication, requiring them to take a second dose or additional rescue medication. A single dose of Nurtec ODT provides rapid relief that lasts through 48 hours. The profile of Nurtec ODT achieves the 4 goals of acute migraine treatment put forth by the American Headache Society, including number 1, rapid and consistent freedom from pain and associated symptoms without recurrence. Nurtec-treated patients achieved rapid pain relief within 60 minutes, as well as freedom from pain and freedom from most bothersome symptom by 90 minutes, and all of these efficacy endpoints were sustained through 48 hours with a single dose. Number 2, restored ability to function. After taking Nurtec, patients returned to normal function by 60 minutes. In a 52-week long-term study, Nurtec significantly reduced migraine-related disability and lost productivity time. Number 3, minimal need for repeat dosing or rescue medications. Only 14% of patients treated with Nurtec ODT used rescue medication within 24 hours. 63% of Nurtec-treated patients who were pain-free at 2 hours remain pain-free through 48 hours without redose or additional rescue medication. And lastly, number 4, minimal or no adverse events. The most common adverse reaction was nausea, which occurred in 2% of Nurtec ODT-treated patients compared to 0.4% on placebo. In the 1-year long-term safety study, only 2.7% of patients discontinued due to an adverse event. No serious adverse events were related to Nurtec, and no clinically relevant lab abnormalities were observed. In summary, 1 75 milligram orally disintegrating tablet of Nurtec provides migraine patients with both rapid and sustained relief without redose or titration. Biohaven respectfully asks the committee to consider adding Nurtec ODT as a preferred agent after trial and failure of up to 2 triptans or a contraindication to triptans, as this is in accordance with guidance from both the American Headache Society and the Institute for Clinical and Economic Review, or ICER. Thank you for your time and attention. I would be happy to answer any questions.
Thank you, Chelsea. Any questions? Okay, thanks again. And we'll move on to Tim Wardell with AbbVie.
Okay, this is Lita. Just a minute while I find him in the list here.
Okay.
Okay, Tim.
Thank you,
Great.
Lita.
You've got
My
3
name
minutes.
is Tim Wardell. My name is Tim Wardell. I'm a pharmacist with AbbVie here to discuss ubrogepant, brand name Ubrelvy, which was approved in December 2019 and indicated for the treatment of acute treatment of migraine with or without aura in adults. Ubrogepant is an oral CGRP receptor antagonist, more similar to Renumab as a receptor blocker rather than a ligand. By blocking CGRP, it reduces or prevents vasodilation rather than blocking vasoconstriction like other migraine-specific agents. Ubrogepant is an oral 50 or 100 milligram tablet taken PRN. A second dose can be taken 2 hours after the initial dose if needed. The maximum dose within 24 hours is 200 milligrams, and it has been studied in patients who have up to 8 migraine days or attacks within 30 days. In clinical trials, as Curtis mentioned, efficacy was studied in triptan-naive, contraindicated, and non-responders in measurement of pain freedom, absence of most bothersome symptoms at 2 hours post-dose. Both the 50 and 100 milligram doses showed statistical significance for both primary endpoints after 1 dose. In those that needed to redose, greater efficacy was seen after a second dose. Ubrogepant was tolerable, as the most common adverse events were nausea and somnolence. Of note, Ubrogepant has one contraindication related to use with strong CYP3A4 inhibitors. It has no warnings and precautions, including CV or medication overuse headache warnings. In our long-term safety extension study, no LFT abnormalities were found. The development was born out of a TrueVan market scan analysis, which demonstrated that episodic migraineurs use 2 times the amounts of opioids and barbiturates compared to control patients. And in concert with the development of Ubrogepant as an option for patients that are unresponsive, contraindicated, or find triptans intolerable, AbbVie partnered with Optum to better understand triptan dosing patterns in patients with acute migraine. In a retrospective analysis, which was presented at AAN and AHS, of more than 12,000 patients with a matched control, more than half did not refill their index triptan, and of those patients, more than 50% switched to an opioid or barbiturate with no improvement in migraine days. Additionally, 22% of patients are contraindicated for triptan use due to the CV risk. With that being said, AbbVie is pleased to offer Ubrogepant as a non-serotonergic option to acutely treat migraine attacks. We respectfully ask for consideration of access in those patients with CV risk and a single step edit in those patients who were unresponsive or intolerable to triptans. Thank you. Be happy to ask any questions if there are.
Thank you, Tim. Any questions for Tim? Okay, thanks again. We'll go next to Carrie Johnson with Amgen.
Okay, hi, can everybody hear me?
Yes, we can. Thanks.
Am I coming through? Great. Okay, thanks so much. My name is Carrie Johnson. I'm a pharmacist with Amgen Medical Affairs. I appreciate the opportunity to provide the committee with an update and testify in support of Aimovig, or Renyumab. Aimovig is a fully human monoclonal antibody to the CGRP receptor. It is indicated for the preventive treatment of migraine in adults. Aimovig can be self-administered using the SureClick auto-injector and comes in 2 dosing options. Of the injectable CGRP products, Aimovig is the only one that specifically targets the CGRP receptor. Aimovig has an established safety and tolerability profile. The most common adverse reactions in clinical studies were injection site reactions and constipation. Recent label updates to the Aimovig warnings and precautions include serious complications of constipation, updated in October of 2019, and new onset or worsening of pre-existing hypertension, updated April of this year. Both updates were a result of post-marketing surveillance. Please see the full Aimovig prescribing information for further details. The recently published American Headache Society, or AHS, consensus statement on integrating new migraine treatments into clinical practice provides the following 2 key recommendations regarding CGRP products. A monoclonal antibody to CGRP or to the CGRP receptor may be prescribed after a 6-week trial of 2 classes of drugs. And secondly, patients who have medication overuse despite the use of preventive treatment may require an escalation dose, a change in preventive therapy, or the addition of another preventive treatment. With this recent update, excluding patients with medication overuse headache from receiving preventive treatment now differs from AHS recommendations. 2 updates specific to Aimovig. Long-term data is available from the registrational STRIVE study in patients with episodic migraine. At the 4.5-year interim analysis of this ongoing 5-year study in patients with episodic migraine, 3/4 of patients receiving Aimovig achieved a 50% reduction in monthly migraine days, along with a reduction in pain intensity. Aimovig was generally well tolerated, no increase in adverse events over time, and no new safety signals were observed. Long-term data is also available from the registrational phase 2 chronic migraine study. At 1 year, 2/3 of chronic migraine patients converted to episodic migraine. Injection site reactions and constipation were the most commonly reported adverse events, and no new safety signals were observed in that long-term data set either. Migraine pathophysiology is multifactorial and complex, and migraine is a very heterogeneous disorder. No 2 patients' migraine experiences or response to treatment are the same. Aimovig has demonstrated long-term safety and efficacy, showing sustained reductions in monthly migraine days, has unique mechanism of action among the injectables, and comes in 2 different dosing options that can be self-administered. We respectfully request that the committee add Aimovig to the preferred drug list so that the providers have therapeutic options. Thank you for your time, and I'm happy to address any questions. The comparative study that was referred to earlier just completed. It was a little delayed because of everything, August, or just a little bit, so we're expecting results anytime now. Any other questions?
Thank you, Carrie. I'm sorry, this is Ginny again. Are there any questions for Carrie? Okay, thanks very much. Are there any?
Sorry, this is Lena. I have one more stakeholder, Maria Agapova. I have unmuted you.
Good day. My name is Maria Gapova. I'm Medical Outcomes Liaison at Teva Pharmaceuticals. Thank you for the opportunity to address the committee this morning. I'm going to be speaking in support of Ajovy farmanemab injection and providing just additional information atop the DUR report. First and foremost, I wanted to update the committee that the Ajovy autoinjector became available in April of this year, making Ajovy the only long-acting self-administered subcutaneous anti-CGRP with the option of monthly and quarterly dosing, allowing for as few as 4 times per year, either with the autoinjector or the pre-filled syringe, which is ultimately very important in this time and day. And I wanted to also provide exploratory analysis looking at that 75% reduction in monthly average migraine days for episodic migraine patients. 1 in 4 reached that threshold of 75% in treatment versus 1 in 7 taking placebo. And then in chronic migraine, 1 in 5 patients achieved 75% reduction in headache days of at least moderate severity compared to 1 in 10 taking placebo. Also wanted to note reductions in acute medication is very important for patients who may be overusing acute medications. And in a post hoc analysis of chronic migraine patients taking Ajovy, we saw pretty nice reductions in that. In the open label extension study period, reversion out of medication overuse endured through month 12 in roughly 60% of patients with acute medication overuse at baseline. And then I'm going to move on to safety. So we looked at 24 clinical studies of Ajovy and 4,777 patients with migraine exposed to Ajovy, and no additional safety signals were seen across the exposed population. Phase 2 and B and Phase 3 pooled data, that's about 2,500 patients. Adverse reports were about 48 to 69%, as was quoted by Dr. Park, but most of those were mild and moderate severity, and serious adverse events and adverse events leading to discontinuation were infrequent and had similar incidence across groups. I wanted to draw your attention to patients' cardiovascular safety profiles. We saw cardiovascular safety profiles similar to placebo, about 1% of adverse events, or patients that had adverse events associated with that. And in patients with cardiovascular medical history, hypertension or hyperlipidemia, those types of risk factors, no new safety signals were detected. In a long-term open label blinded extension study, hypertension occurred in 2% of Ajovy treated patients. No worsening of hypertension over 12 months in patients with history of baseline hypertension was observed. And then in the post-marketing period, hypertension has not been identified as a safety signal. And just to note, we did look at the FAERS database analysis normalizing by claims and saw the post-marketing adverse event profiles do differ by monoclonal antibody, and that analysis was presented recently at AN. And then moving to constipation.
Maria, this is Committee Chair. I just wanted to let you know your 3 minutes are up, and so if you'd like to conclude, that would be great. Thank you.
Sure, I was on my last sentence. I was moving from hypertension to constipation, and again, showing that only 1% of patients reported constipation, and that was correlated in the post-marketing data as well. Thank you. I apologize for the little overage.
No problem. My apologies for interrupting your last sentence. Any questions for Maria? Thank you very much. All right, so I believe that concludes our stakeholders for CGRPs, and it looks like we can move to the motion.
This is Alex Park. I'm looking at the motion, and I would like to recommend we strike the last paragraph about eptinizumab in light of the new data that Curtis provided. Open to discussion from the committee on that.
This is Ginny, and I would agree with you. That seems like an appropriate change to make.
This is Alex Park. Thanks, Ginny. let's see, Lita, if we do that, we'll probably also want to put eptinizumab into the body of the first paragraph.
And this is Donna. Was this a full report, an update?
This is Lita. Yes, it is.
And so are those other 2 products on the market? Do those need to be added?
Yes, if the committee wants them added.
This is Alex Park. So if we did that, do we have to create a separate paragraph, Donna? Because it looks like we're talking about the original 4 drugs in terms of migraine prophylaxis, and the other 2 new agents would be more acute treatment.
If you feel that they should be included in the class, and if you feel that they should be first-line treatment, you could put them in there, or you could make another paragraph or just add another sentence.
I would be in favor of doing a separate paragraph calling out those 2 drugs for acute treatment as second line, given the short-term single attack design of the trials and the relative newness of their FDA approval.
This is Nancy. I would echo that. And it's not for, this is Nancy, it's not for treatment of chronic migraine, is it, or acute?
Acute.
Yep.
And this is Lita.
Thanks,
Do you
Nancy.
want me to put as a second line agent in that sentence?
This is Alex Park. I think that would be appropriate. This is Alex Park. Donna, do we have to say something about interchange for those as well?
Yes, you should.
Okay, thanks.
And they would be subject to interchange between the 2, not between the entire class.
Yes, that makes sense because of their unique approvals for acute treatment. This is Alex Park. After considering the evidence of safety and efficacy for the treatment of migraine prophylaxis, I move that eptinizumab, erinumab, fremonizumab, galcinizumab are safe and efficacious for the treatment of their approved indications. The CGRP inhibitors should be second-line agents on the Washington PDL. Actually, Lita, sorry, this is my OCD. Could we say these CGRP inhibitors should be second-line, just calling out the chronic versus acute thing? Thanks. Erinumab, fremonizumab, and galcinizumab. Sorry, we should add eptinizumab at the end of that line of drugs there. So thank you. Erinumab, eptinizumab, fremonizumab, and galcanezumab can be subject to therapeutic interchange in the Washington Preferred Drug List. After considering the evidence of safety and efficacy for the treatment of acute migraine, I move that rimegepant and ubrigepant are safe and efficacious for the treatment of their approved indications as second-line agents on the Washington PDL. Rimegepant and ubrigepant can be subject to therapeutic interchange with each other in the Washington Preferred Drug List.
This is Nancy Lee. I second that motion.
Oops, sorry. And this is Jenny, committee chair. All those in favor?
Aye.
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 Are there any opposed? Okay, reiteration of the prior motion carries. Thanks for the expert wordsmithing on that motion. I believe that we are going to go ahead and adjourn the P&T committee portion of our meeting. It was a quick one this morning, and that we will convene the DUR board, and we will look to Umang Patel to start our review of oncology agents.
Umang, we can't hear you. I don't see that you are on audio. You may not have put in your audio PIN number.
Can you hear me?
Yes, now we
Can
can
everyone
hear
hear
you.
me now?
Great.
There we go.
Yeah, thank you.
Perfect. So, okay. And can everyone see my webcam is on as well?
Yes.
Okay, great. So we'll go over some of the topics here today. Just to remind the committee, as we did in June, what we will do is more of an updated review of some of these topics. Any new clinical information, new medications, updates to formulations or strengths or indications in the last 1 year will be reviewed. Otherwise, anything older than that will not be reviewed. Some of these classes do not have any reviews whatsoever, and so there is no information that will be reviewed there. And we'll go ahead and get started. For the first class, or large umbrella class, will be oncology agents. So if you could go to slide 4, Lita. We've broken these down into the different, no problem.
Oops, okay, sorry.
No problem at all.
There we go, got it.
Okay, so if you go to slide 4, please. We've broken these down into the subclasses that Apple Health PDL has them divided into.
Just a minute, I'm having technical problems here.
No problem.
Okay, I'm just gonna do it like this.
Okay, perfect. So as you can see here, there are going to be 13 different subclasses here. We do have the androgen biosynthesis inhibitors that have no updates. Again, bold on this slide does indicate the specific medication has an update. Anti-androgen oral medications, updates for Erledia and Xtandi. The next subclass will be anti-neoplastic miscellaneous, and we'll have an update regarding Kisqali Femara. We have the BRAF kinase inhibitors, along with the cyclin-dependent, or the CDK inhibitors, where we'll review Braftovi and Ibrance. FGFR kinase inhibitors and the Hedgehog pathway, along with the MEK inhibitors, do not have any updates there. We'll have the mTOR kinase inhibitors, reviewing everolimus, and no updates for the multi-kinase inhibitors. And then for the ADP ribose, the PARP inhibitors, we will touch on Zejula, Lynparza, and Rubraca. And then there are no updates for the retinoids or topoisomerase inhibitors, or the tropomyosin receptor kinase inhibitors either. So moving on to our first medication here. On the next slide, you see Erleda. I apologize for my pronunciation. Some of these are a little bit tough. Again, bold on these slides does indicate pertinent updated information. So in September 2019, FDA approved expanded indication for the treatment of metastatic castration-sensitive prostate cancer. Previously, it was only approved for non-metastatic castration-resistant prostate cancer. Again, the warning and precautions are all the same. I will go over them initially, and if there are any differences in different classes, then I'll highlight those. So there are warning and precautions for ischemic cardiovascular events can occur in patients receiving treatment. Fractures have occurred in patients. Falls have occurred in patients receiving treatment with increased incidence in the elderly, as one can imagine. Seizures occurred in less than 1% of patients receiving treatment. And lastly, embryo-fetal toxicity as well. The dosage and availability are there for the committee's reference. And in terms of special populations, for patients who are renally impaired, there are no clinical significant differences in renal or hepatic impairment, being mild to moderate. And for hepatic, that's Child-Pugh A as in alpha or B as in beta. For severe renal or hepatic impairment, there's unknown effects on the PK on the pharmacokinetics. On the next slide here, we'll next pivot over to Xtandi. And in December 2019, the FDA approved expanded indication for the treatment of patients with metastatic castration-sensitive prostate cancer. It was already indicated for patients with castration-resistant prostate cancer. The warning and precautions are very similar to the previous slide, so I won't go over them again. And the dosage and availability, as you can see, are available here. Some of these slides may go faster than others because these are all kind of lumped in the same class. There are a lot of overlap, and just for time's sake, since my time is limited for these classes, I will kind of go through them. But if the committee has any questions, I'm more than happy to go back or review something specifically as well. On the next slide here, we do have Kisqali, Femara, Copax. So in September 2019, FDA approved expanded indication for the initial endocrine-based therapy for the treatment of pre- and perimenopausal or postmenopausal women with HR-positive, HER2-negative, advanced or metastatic breast cancer. Previously, this was approved in postmenopausal women only. Now, for the warning and precautions, there are some different ones to highlight here, so I'll only look at the ones that are different from the previous. There is a QT interval prolongation, so it's recommended to monitor EKGs and electrolytes prior to treatment, repeat EKGs approximately day 14 of the first cycle and beginning of the second cycle, and as clinically required. Hepatobiliary toxicity, so there is an increase in transaminase levels. So LFTs, monitoring LFTs is recommended every 2 weeks for the first 2 cycles. Neutropenia, as one can imagine. It is recommended to perform a CBC before initiating therapy and to monitor them every 2 weeks for the first 2 cycles. And lastly, as I mentioned before, embryo-fetal toxicity in a lot of these oncology medications. No update to the dosing and availability. And for special populations, for renal impairment and hepatic impairment, there's no adjustment in mild to moderate for either of those. And there is a dose reduction in the ribociclib portion to 200 milligram once daily, and no adjustment for letrozole for renal impairment. And to flip it, for hepatic impairment, there is a reduction in letrozole to 2.5 milligrams and a lower dose for ribociclib as well. Moving onward to the next medication we do have is Braftovi. In April 2020, FDA approved the new indication in combination with cetuximab for the treatment of adult patients with metastatic colorectal cancer with a BRAF V600E mutation as detected by an FDA-approved test after prior therapy. It is not indicated for the treatment of patients with wild-type BRAF melanoma or wild-type BRAF CRC. And then additionally, separately from this, but in April 2020 as well, FDA approved a companion diagnostic, the TheraScreen BRAF V600E RGQ PCR kit for the approved indication that I mentioned a second ago. It does have other indications, as you can see under the indications tab here. The warning and precautions are very similar to the previous ones. Some of the newer ones being new primary malignancies, cutaneous and non-cutaneous, can occur. It is recommended monitor for malignancies and perform dermatologic evaluations prior to, during, and following discontinuation of treatment. Tumor promotion in BRAF wild-type tumors have increased. Cell proliferation can occur. And lastly, major hemorrhagic events can occur as well. Moving on to the next slide here, we do have Ibrance. And this is, in November 2019, FDA approved a new tablet formulation. So the indications, no changes there. It was a kinase inhibitor indicated for the treatment of adult patients with hormone receptor positive human epidermal growth factor receptor 2, negative advanced or metastatic breast cancer in combination with an aromatase inhibitor for initial treatment in postmenopausal women or in men, or in combination with fulvestrant in patients with disease progression following endocrine therapy. In terms of warning and precautions, you do see some of the same ones, except interstitial lung disease or pneumonitis has been seen. Severe or fatal cases have been reported, and it is recommended to monitor for pulmonary symptoms. And as I mentioned, there was a new formulation of tablets. As you can see, the dosing is identical to the capsules. It just now comes in a tablet form. Moving onward to Afinitor. So in January 2020, FDA approved the first generic for Afinitor from Par Pharma for 2.5, 5, and 7.5 milligrams, and Teva, again, 2.5, 5, 7.5, and 10 milligrams. And Par and Endo have announced they have launched their products already, and this was, again, 8 months ago. Indications, here you can see postmenopausal women with advanced HER2 negative breast cancer in combination with exemestane after failure of treatment, adults with progressive neuroendocrine tumors of pancreatic origin, and adults with progressive, well-differentiated, non-functional neuroendocrine tumors of GI or lung origin that are unresectable, locally advanced, or metastatic, adults with advanced renal cell carcinoma after failure of treatment with sunitinib or sorafenib, and lastly, adults with renal angiomyolipoma and tuberous sclerosis complex, not requiring immediate surgery. Again, there is a black box warning with this medication. Only physicians experiencing with immunosuppressive therapy and management of transplant patients should prescribe this medication. And to avoid nephrotoxicity, reduce doses of the medication when used in combination with cyclosporin. Dosing and availability, as you can see, are listed below. Moving onward, so next is Zejula. Now in May 2020, FDA approved a new indication for the maintenance treatment of adult patients with advanced epithelial, ovarian, fallopian tube, or primary peritoneal cancer who are in complete or partial response to first-line platinum-based chemotherapy. Previously, it was indicated only for the maintenance treatment of adult patients with recurrent epithelial ovarian, fallopian tube, or primary peritoneal cancer who are in complete or partial response to platinum-based therapy. Again, no significant different warning or precautions here, and dosing and availability is unchanged as well. Dosing is stratified by indication and can be found in the TCRs that are in the web portal for the committee or in the package insert. On the next slide, we have Lynparza. Now, there were multiple updates to this medication, so I kind of broke it down by significant updates, even though the dates are the same. In May 2020, FDA approved a new indication for the maintenance treatment of adult patients with deleterious or suspected deleterious G-BRCA metastatic pancreatic adenocarcinoma whose disease has not progressed on at least 16 weeks of a first-line platinum-based chemotherapy regimen. In the same month and year, FDA approved in combination with bevacizumab for the maintenance treatment of adults with advanced epithelial ovarian, fallopian tube, or primary peritoneal cancer who are in complete or partial response to first-line platinum-based chemotherapy and whose cancer is associated with homologous recombination deficiency, positive status defined by either a deleterious suspected or suspected deleterious BRCA mutation, and or genomic instability. And lastly, same month and same year, FDA approved a new indication for the treatment of adults with deleterious or suspected deleterious germline or somatic homologous recombinant repair gene-mutated metastatic castration-resistant prostate cancer in patients who have progressed following prior treatment with enzalutamide or abiraterone. Indications, as you can see, I reviewed them there. With warning and precautions, very similar warning and precautions coming through. A newer one here, venous thromboembolic events can occur, including pulmonary embolism in up to 7% of patients with MCRPC. Monitor patients for signs and symptoms of VTE or PE and treat as medically appropriate. Now, the last medication here we have are Rubraca. So in May 2020, the FDA approved a new indication for the treatment of adults with deleterious BRCA mutations, germline and or somatic, associated metastatic castration-resistant prostate cancer who have been treated with androgenic receptor directed therapy and a taxane-based chemotherapy. The FDA approved a test to detect the BRCA1, BRCA2 mutations in patients with MCRPC, but it is not currently available yet. As you can see, the indications are stratified by ovarian and prostate cancer, the update being in the prostate cancer indication with the warning and precautions. A newer one that we're seeing today is MDS AML. So it can occur in patients exposed to treatment, and some cases were fatal. Monitor patients for hematologic toxicity at baseline and monthly, and discontinue the medication if it is confirmed. Now, so with oncology agents, that concludes the first half of the oncology agents. I know according to the agenda, there is a break here before we resume to TKI, so I will pause here for the committee chair.
This is Ginny, just chiming in, looking for feedback from the group if they'd like to continue with the oncology agents or take a break. Right, I don't hear any feedback, so I'm going to go ahead and stick with the agenda, and let's see. Well, sorry to be wishy-washy. We're not at 10:45 yet. So Umang, do you want to go? Are you comfortable going ahead? All right.
Absolutely. I just wanted to make sure I didn't stray from the agenda.
Oh no, thank you very much. We'll go ahead and finish up that section and then go to break. Thanks.
Perfect. So on the next slide here, you'll see that oncology agents, as I mentioned earlier, were broken down by different subclasses. So here you can see the next class we'll be going over are the TKIs, and this is a more substantive class. That's why it kind of received its own little category on the agenda. As I mentioned earlier, the bold indicates significant clinical information. So we'll be reviewing Calquence, Inleta, Avakit, Allenbrig, Tabrecta, Lenvima, Nerlynx, Tralio, Kinlock, Tukisa, and Brukinsa as well. And again, I apologize if I mispronounced any of those. Moving right along. So the first medication here, we have Calquence. So in November 2019, FDA approved a new indication for the treatment of adult patients with CLL, chronic lymphocytic leukemia, or SLL, small lymphocytic lymphoma. It was already approved for adults with mantle cell lymphoma, MCL, who have received at least one prior therapy. Warning and precautions, serious and opportunistic infections may occur, so it is very important to monitor for signs and symptoms of infection and treat promptly. Hemorrhage, cytopenias, as we mentioned, being the oncology class, that's somewhat expected. And lastly, AFib and atrial flutter, so monitor for symptoms of arrhythmia and manage appropriately. No dosing or availability changes here. Moving right along, to the next update is for Inleta. So for Inleta, in June 2020, FDA approved a new indication in combination with avelumab or pembrolizumab for the first-line treatment of patients with RCC, advanced renal cell carcinoma. Previously, it was approved as a single agent for the treatment of advanced RCC after failure of one prior systemic therapy. As you can see, it does have a tertiary, it does have the other indication I just mentioned, unbolded. In terms of warning and precautions, hypertension and hypertensive crisis are something to monitor with this medication. It has been observed, so blood pressure should be well controlled prior to treatment, and obviously monitoring during and after treatment is recommended. Arterial or venous thromboembolic events have been observed as well, and can be fatal, as one can imagine. So use with caution patients who are at increased risk for these events. And lastly, cardiac failure. So cardiac failure has been observed in patients taking this, and as you can imagine, it can be fatal. So monitor for signs and symptoms throughout treatment. Dosing and availability, there are no changes here. Okay, moving right along to AYVAKIT. So in January 2020, FDA approved a new drug indicated for the treatment of adults with unresectable or metastatic GI stromal tumor, or GIST, harboring a platelet-derived growth factor receptor alpha exon 18 mutation, including PDGFRA D842V as in Victor mutations. Since this is a new drug, I'll kind of go through all of the information for this. The warning and precautions: intracranial hemorrhage has been noticed. Withhold treatment for grade 1 or 2 reactions until resolution, and then resume at a reduced dose. Permanently discontinue this for a grade 1, for recurrent, grade 1 or grade 2 reactions, or first occurrence of a grade 3 or grade 4. There have been some CNS effects, primarily things such as cognitive impairment, dizziness, sleep disorders. It depends on the severity. You can continue this medication at the same dose, withhold it, or and then resume it at the same dose, or just reduce it. Again, it depends on the symptom and the severity of it. And lastly, embryo-fetal toxicity, as we've mentioned before with other comparable medications. Dosing is 300 milligrams once daily, and the availability here in tablets is 1, 2, and 300. Since this is a new drug here, pediatrics, there have been no safety and efficacy established for any pediatric patients. In terms of impairment for both renal and hepatic, mild to moderate in both renal and hepatic require no dosage adjustment. In terms of severe, the dosage is not yet established yet. Now, moving right along to the next medication, Allenbrig. So in May 2020, FDA approved a new drug indicated for the treatment of adult patients with anaplastic lymphoma kinase, or ALK positive metastatic non-small cell lung cancer, as detected by an FDA-approved test. Patients should be selected for treatment of metastatic NSCLC based on the presence of ALK positivity in tumor specimens. Now, in terms of warning and precautions, there is ILD and pneumonitis, which we saw in similar medications previously, hypertension as well. I'm not going to review if warning or precaution has already been touched on by a similar medication. I won't review that specifically. Bradycardia. So healthcare practitioners are recommended to monitor heart rate and blood pressure regularly during the treatment. And if patients are symptomatic, withhold. And then once the bradycardia has resolved, you can restart the treatment at a lower dose. And then embryo-fetal toxicity as well. The dosage here is 90 milligrams once daily for the first 7 days. Increase it to 180, and the availability in tablets is there in front of you. Similarly to the previous medication, pediatric safety and efficacy has not been established in this one, and dose adjustment, dose reduction adjustment is recommended only for severe renal and hepatic impairment, nothing for mild or moderate in either renal or hepatic. The next medication here, we have Tabrecta. In May 2020, FDA approved a new kinase inhibitor indicated for the treatment of adult patients with metastatic non-small cell lung cancer whose tumors have a mutation that leads to a mesenchymal epithelial transition, exon 14 skipping, as detected by an FDA-approved test. And then the FDA also approved the Foundation 1 CDX assay as a companion diagnosis test. Warning and precautions. As we've seen before, ILD, pneumonitis, and embryo-fetal toxicity. A newer one that we've yet to see hepatotoxicity, so it is important to monitor liver function tests, withhold, dose, reduce, or permanently discontinue based on the severity. Dosing is 90 milligrams once daily for the first 7 days, and you increase it to 180, and the availability in tablets is 150 and 200. Moving onward here, we do see the next medication being Lenvima. And so in September 2019, FDA approved expanded indication for the use in combination with pembrolizumab for the treatment of advanced endometrial carcinoma, that is not MSI-H or DMMR, in patients with disease progression after systemic therapy and are not candidates for curative surgery or radiation. As you can see, it does have a litany of other indications as well here. The dosage is indication-based as well, as you can see in front of you. And the availability is in capsule forms here. In terms of impairment, very similar to others, severe hepatic or renal impairment does require dose adjustment. Mild to moderate does not. Okay, on to the next slide. Here we have Nerlynx. So in February 2020, FDA approved for the use in combination with capecitabine for the treatment of adult patients with advanced or metastatic HER2-positive breast cancer who have received 2 or more prior anti-HER2-based regimens in the metastatic setting. It was already indicated as a single agent for the extended adjuvant treatment of adults with early-stage HER2-positive breast cancer to follow adjuvant trastuzumab-based therapy. As I mentioned earlier, with similar medications, warning and precautions here: hepatotoxicity, embryo-fetal toxicity. Dosing, as one can imagine, is indication-based, so it's stratified here, and availability is found below. Moving right along to the next medication is Turalio. And so for this medication here, August 2019, FDA approved Turalio for the treatment of adults with symptomatic tenosynovial giant cell tumor associated with severe morbidity or functional limitation and not amenable to improvement with surgery. In terms of warning and precautions, there's embryo-fetal toxicity with this as well, and there are some black box warnings that would be fruitful to review. It can cause serious and potentially fatal liver injury. So it's recommended to monitor LFTs prior to treatment and at specified intervals, withhold a dose or reduce, or permanently discontinue if the patient does show signs of hepatotoxicity on any spectrum. And it is available only through a restricted program called the Turalio REMS program. Recommended dosing is 400 milligrams twice daily, and the availability is in capsules, 200 milligrams. For this medication, again, safety and efficacy in pediatrics has not been established, and only mild to severe renal impairment does require dose adjustment, and moderate to severe hepatic impairment does not have established dosage adjustment yet. Moving on to the next medication here is Qinlock. And so for Qinlock, we do see in May 2020, FDA approved this medication for the treatment of advanced GI stromal tumor who have received at least prior treatment with 3 or more kinase inhibitors, including imatinib. The warning and precautions very similar: embryo-fetal toxicity. Newer ones that we are seeing here: risk of impaired wound healing. So it is recommended to withhold the treatment for at least 1 week prior to elective surgery, do not administer for at least 2 weeks after a major surgery, and until adequate wound healing. The safety and resumption of this medication after resolution of wound healing complications have not been established yet. New primary cutaneous malignancies have been observed, so it is recommended to perform dermatologic evaluations when initiating this medication and routinely during treatment. And lastly, cardiac dysfunction. And it's recommended to assess ejection fraction by echocardiogram or a MUGA scan prior to initiating treatment, during, as clinically indicated, and to discontinue if the patient has grades 3 or 4 left ventricular dysfunction. systolic dysfunction, excuse me. Recommended dosing is 150 once daily, and it's available in tablet forms. The
Umang?
next medication, yes.
Umang, this is Lita. Can we pause here and take a 10-minute break? Ginny, the committee,
Totally fine with
is
me.
that okay?
Of course, and my apologies for missing that break mark. Thanks, Lita.
Oh, no problem. Okay, so let's reconvene at, I guess, 11. It's 10:48.
That sounds great.
Okay, thank you.
Hi, this is Ginny. We're coming back from break. Umang, we'll go ahead and turn it back to you to finish. We go to our stakeholders. Thanks.
Sounds great. Okay, so we'll pick up right where we left off. On the next slide, we'll pick up with Takisa. Perfect. So in April 2020, FDA approved this medication for the treatment of adult patients with advanced unresectable or metastatic HER2-positive breast cancer, including patients with brain metastases who have received one or more prior anti-HER2-based regimens in the metastatic setting. The warnings and precautions, some of them, as you can see, are very common. Embryo-fetal toxicity, we've reviewed. Hepatotoxicity as well. Diarrhea, so severe diarrhea has been seen with this medication, including dehydration, acute kidney injury, and death have been reported. So it is recommended to administer anti-diarrheal treatment as clinically indicated. The recommended dosage, 300 milligrams twice daily with or without food. And there is a dose adjustment if a patient is hepatically impaired as well. And the availability in tablets is right there as well. Now, on the next slide, the last medication in the kinase inhibitor class we have is Brukinsa. So in November 2019, FDA approved Brukinsa for the treatment of adult patients with mantle cell lymphoma who have received at least one prior therapy. In terms of this indication is approved under the Accelerated Approval Program based on overall response rate. Continued approval of this indication may be contingent upon verification and description of the clinical benefits based in a confirmatory trial. Warning and precautions, a lot of these, again, embryo-fetal toxicity we've discussed, hemorrhage as well. Patients can be at an increased risk of infections, so it is incumbent to monitor for signs and symptoms. Cytopenias, as we've discussed before. Secondary primary malignancies, so patients have been observed to have other malignancies, including skin cancers. So it's advised to tell patients to use sun protection. And lastly, cardiac arrhythmias such as AFib and aflutter. The dosage, 160 milligrams twice daily or 320 once daily. And there is a dose adjustment recommendation for hepatic impaired patients. And the availability here, as you can see, is in capsules. That is the overarching oncology medications we've gone through, which had various subclasses along with ending it with the TKIs. Any questions at all?
Thanks, Umang. That was a lot of information. We appreciate it. Any questions from the committee? Okay, we're ready to move to stakeholder input. It looks like we have 4 stakeholders listed. If you don't hear your name called, could you please raise your hand and let us know? We will be hearing from Vilasini Ravanam with Pfizer, Mark Balk with BeiGene, Julie Baker with Deciphera Pharmaceuticals, and Long Win with GSK. So we'll go first to Dr. Ravanam with Pfizer, and you'll have 3 minutes for your comments.
Hello, thank you. Can everyone hear me?
Yes, we can. Thank you.
Okay. So my name is Veela Ravanam with Pfizer Oncology Medical Affairs. By training, I have a PhD in clinical oncology. I'm here to provide the committee with efficacy and safety information for Braftovi in BRAF mutant metastatic colorectal cancer, the first and only approved targeted regime for this population of patients. So based on SEER data and published literature from American Cancer Society, the estimated numbers of patients with metastatic CRC is close to 147,000, and of this, about 50% have the BRAF mutations. Coming to the indication, Braftovi or encorafenib is indicated in combination with cetuximab for the treatment of adult patients with metastatic CRC harboring a BRAF V600 mutation as detected by an FDA-approved test after prior therapy. Limitations of use is that this drug is not indicated for the treatment of patients with wild type BRAF CRC. According to the current NCCN guidelines, Braftovi in combination with cetuximab is the only category 2A recommendation in BRAF V600E mutant patients who had progression on therapy for advanced or metastatic disease and who have not been previously treated. As for the rationale, co-administration of Braftovi with cetuximab had an anti-tumor effect greater than either drug alone in mouse models of CRC with this unique mutation, the BRAF V600E. So Braftovi is a kinase inhibitor of BRAF V600E as well as wild-type BRAF and CRAF. Cetuximab is a monoclonal antibody antagonist that binds EGFR. The recommended starting dose of Braftovi is 300 milligram, 475 milligram capsules taken orally once daily. There are recommended dose adjustments for certain AEs for Braftovi, and as for cetuximab, it's advised to refer to the prescribing information for on recommended cetuximab dosing information. Related to efficacy in the randomized phase 3 actively controlled open-label trial on patients who were previously treated and with a disease progression of 1 or 2 prior therapies, these patients were treated with a combination of Braftovi and cetuximab and demonstrated statistically significant improvement in overall survival compared to the control arm, showing a median overall survival of 8.4 months versus 5.4 months on the control arm, which is FOLFIRI with cetuximab or irinotecan with cetuximab. The median follow-up for this was 7.8 months. As for the clinical safety profile, the most common AEs, all grades occurring in more than 25% of the patients who received this combination were fatigue, nausea, diarrhea, dermatitis, abdominal pain, decreased appetite, arthralgia, and rash. Other clinical important AEs occurring in less than 10% of the patients with cetuximab was pancreatitis. The most common lab abnormalities greater than 20% all grades as compared to the control arm were mainly anemia and lymphopenia.
Dr. Ravana,
yes.
I'm sorry to interrupt, just to let you know your 3 minutes are up. If you could conclude.
Okay, and just a last sentence that in conclusion, adding this combination will offer a new treatment option for these patients. And with that, I'll stop here and I can take any questions at this time.
Thank you very much, Dr. Ravanam. Are there any questions from the committee? Okay, thank you again. We'll go ahead and move to Mark Balk with Beijing.
Great, thank you very much. As mentioned, my name is Mark Balk. I'm a PharmD with Medical Affairs from Beijing. Let me just stop and ask and verify that you can hear.
Yes, we can. Thank you.
Perfect. Thank you. And thanks to Umang for doing a nice job of going through the drug review. So I'll talk about zanubrutinib, Brukinsa, in a very accelerated fashion. So as Umang mentioned, it's been approved as a BTK or Bruton tyrosine kinase inhibitor for treatment of adult patients with mantle cell lymphoma who have received at least 1 prior therapy. So those patients that are relapsed refractory. And it was approved by the FDA November 14th of 2019 and then incorporated into the NCCN clinical guidelines for mantle cell lymphoma within 2 weeks later. So the efficacy of Brukinsa was assessed in 2 different studies that are outlined in the package inserts. I won't cover those to any great extent, except just going on to the primary efficacy endpoints. That for both studies, the overall response rate assessed by independent review committee was consistent at 84% across both studies, including complete response rates of 59% in the phase 2 study and 22% in the phase 1-2 dose ranging study. For safety, there are no contraindications to the use of Brukinsa. Warnings and precautions were outlined nicely again by Umang, and those are by and large class effect for the BTK inhibitors. So the most common adverse reactions include neutrophil count decrease, the cytopenias that Umang had mentioned. So neutropenia, thrombocytopenia, upper respiratory tract infection, rash, bruising, diarrhea, and cough. So some of the other important aspects that Brukinsa or zanubrutinib can be given in either a 320 milligram once daily or 160 milligram twice daily regimen, can be given with or without food. No clinical significant differences in pharmacokinetics was observed when given with gastric acid reducing agents. No adjustment of dose needed for patients with mild to moderate renal or hepatic insufficiency. And Brukinsa can be used with dose reductions with strong or moderate CYP3A inhibitors and in patients with severe hepatic insufficiency. One other thing that I'll mention is that just the pricing on the drug has been introduced at about 7 to 8% lower WAC than some of the other, or the two competitive agents on the market. Lastly, just the request that given Brukinsa's efficacy and safety profile, we'd ask the members of the committee to consider the data presented and allow for patients with relapsed refractory MCL in the state of Washington to have access to Brukinsa. I'll stop there within my 3 minutes.
Thanks, Dr. Balk. Any questions from the committee? Okay, we'll move on. Thank you. Going next to Julie Baker.
Good morning. Good morning. My name is Julie Baker with Medical Affairs, representing Decipher Pharmaceuticals, and I appreciate having the opportunity to present some information on Qinlock, which is also known as ripretinib, and which was very well reviewed by Umang a minute ago. Qinlock is indicated for the treatment of adult patients with advanced gastrointestinal stromal tumor, also known as GIST, who have received prior treatment with 3 or more kinase inhibitors, including imatinib. The recommended dosage of Qinlock is 150 milligrams orally once daily with or without food until disease progression or unacceptable toxicity. Qinlock has been proven effective in Invictus, an international multi-center double-blind placebo-controlled trial. 129 patients were randomized in a 2-to-1 ratio to Qinlock, 150 milligrams once daily or placebo. Primary efficacy outcome measures were PFS based on disease assessment by blinded independent central review using modified RECIST 1.1 criteria. And the median PFS was significantly improved with Qinlock compared with placebo, which was 6.3 months versus 1 month. The hazard ratio was 0.15 and the p-value was less than 0.0001. Most common adverse reactions in 20% or more of patients were alopecia, fatigue, nausea, abdominal pain, constipation, myalgia, diarrhea, decreased appetite, palmar-plantar erythrodysesthesia syndrome or PPES, and vomiting. Most common grade 3 or 4 lab abnormalities in 4% or more were increased lipase and decreased phosphate. Serious adverse reactions that occurred in more than 2% of patients were abdominal pain, anemia, nausea, and vomiting. Regarding warnings and precautions, with PPES in Invictus, grade 1 to 2 PPES occurred in 21% of the 85 patients who received Qinlock, and based on severity, you should withhold and then resume at the same or reduced dose. Regarding new primary cutaneous malignancies in Invictus, cutaneous squamous cell carcinoma occurred in 4.7% of 85 patients who received Qinlock, with a median time to event of 4.6 months and a range of 3.8 to 6 months. Melanoma occurred in 2.4% of the 85 patients who received Qinlock. With hypertension in Invictus, grade 1 to 3 hypertension occurred in 14% of the 85 patients who received Qinlock, including grade 3 hypertension in 7%. Do not initiate in patients with uncontrolled hypertension, and based on the severity, withhold and then resume at the same or reduced dose or permanently discontinue. With cardiac dysfunction in Invictus, cardiac failure occurred in only 1.2% of the 85 patients who received Qinlock. Grade 3 decreased ejection fraction occurred in 2.6% of the 77 patients who received it and who had a baseline and at least one post-baseline echocardiogram. Safety has not been assessed in patients with a baseline ejection fraction below 50% and permanently discontinued for grade 3 or 4 left ventricular systolic dysfunction. Regarding risk of impaired wound healing, Qinlock has the potential to adversely affect wound healing. Withhold for at least 1 week prior to elective surgery and do not administer for at least 2 weeks following major surgery and until adequate wound healing. Lastly, embryo-fetal toxicity based on findings from animal studies and its mechanism of action. Qinlock can cause fetal harm when administered to a pregnant woman. Advise pregnant women of the potential risk to a fetus. And lastly, please refer to the Qinlock prescribing information for complete product info, including warnings and precautions. I'll close with a statement that will request, based on today's testimony, Decipher Pharmaceuticals requests that Qinlock be added to the preferred drug list. I thank you, and I will be happy to answer any questions you may have.
Thank you, Julie. Any questions from the committee? Okay, thanks. Moving next to Long Win with GSK.
This is Lita Long. I see that you are self-muted.
Yes, can you hear me now?
Yes.
Yes.
Great. Thank you, everyone. Good morning, and my name is Long Nguyen, and I am the Health Outcome Liaison at GlaxoSmithKline, here to provide you additional comments on Zejula. Prior to the year 2020, PARP inhibitors monotherapy are only indicated for ovarian cancer patients with a BRCA-positive status, which comprise of only about 25% of all patients diagnosed with this disease. The other 75% of patients with a BRCA negative status are more difficult to treat with limited options available. Like Dr. Patel mentioned in his report, Zejula was approved in May as a monotherapy for the maintenance therapy for all patients with advanced epithelial ovarian, fallopian tube, or primary peritoneal cancer who are in a complete or partial response to first-line platinum-based chemotherapy in all patients, regardless of biomarker status. And unlike other PARP inhibitor, the indication does not require an FDA-approved companion testing. The approval based on the results of the PRIMA registration trial demonstrated a 50% and 60% reduction in risk of progression and death in patients with a BRCA negative and BRCA positive biomarker status, respectively. This expanded patient population indication received a Class 2A recommendation as a preferred single agent from the updated NCCN guidelines in March of this year. The approval of the PRIMA trial also include an implementation of an individualized dosing strategy where patients weighing less than 77 kilo and or a platelet count of less than 150,000 cells per microliter should initiate Zejula at 200 milligram instead of the normal starting dose of 300 milligram once a day. The implementation of an individualized dosing regimen reduced the incidence of grade 3 or more hematologic adverse event seen in the trial by 35 to 59% compared to the fixed dose regimen. In summary, Zejula is currently the preferred PARP inhibitor on the Washington PDL and Apple Health drug list. And with the advantages of Zejula discussed previously over other agents in the same class, I ask that the committee continue to maintain its status, allowing more patients diagnosed with this dismal disease to be treated. Thank you so much for your time and attention, and I'll be happy to address any questions the committee may have.
Thank you, Dr. Nguyen. Any questions from the committee? Okay. Are there any other stakeholders who didn't have a chance to be heard?
This is Lita. I do not see any other stakeholders.
Okay. Let's go ahead and move to the motion.
Hi, Jenny. Sorry to interrupt. This is Marissa. I forgot to mention at the beginning, you should have gotten a link to the PDL publication. So it just because we're all digital now, we couldn't offer anything printed. We did offer you guys a link to the publication so you could see what products are preferred and non-preferred. So if you wanted to review any of those particular classes, just let me know and we can go through them on the publication if you would like, or any other committee members as well.
Thank you, Marissa. Yeah, I'll open it up, make sure the committee gets a chance to chime in now. If there's anything specific, we should pause to review.
Okay, sounds great. And you should be able to search for it using the filters at the top. So if anybody has any issues, just let me know and we can kind of walk through how to use it.
Okay, great. Committee members, is there need for any time or specific questions about reviewing that document? Does everyone feel ready to move to the motion? Just chime in if you are not ready. Okay, so we'll move back to the motion then.
This is Lita. If you want to tell me when you're ready for the next slide.
Thanks, Lita. Let me just bring my camera up to feel a little more active. Yeah, I would go ahead, please, and go ahead to the next slide. And we'll give a minute there. Okay, I'm going to have Lita go ahead. Again, committee, chime in if we're moving too fast or we need to stop. We'll pause here. And we'll go ahead to the next slide.
Hi, Jenny. So this is Connie. All right, so this is Connie Nguyen. I move that all products in the drug classes listed on slides 2 and 3 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in these classes may require prior authorization to determine medical necessity. All non-preferred products require a trial of 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Jordan Storhaug. I second the motion.
And this is Ginny Bucola. All those in favor, please say aye.
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 Any opposed? The motion carries.
This is Lita. Since we're just at 11:22, I would suggest continuing with the ophthalmic agents up until around 12 o'clock when we can have lunch. Does that work?
That sounds great to me. If Umang's ready to go, let's go for it.
Absolutely. Sorry about that. Okay. We'll go ahead and move right along to the ophthalmic agents, specifically glaucoma agents here. As I mentioned earlier, again, just to remind the committee, we're only focusing on any new pertinent information in the last year. So older guidelines will not be reviewed. They are found in the TCR that is in the web portal for the committee. Anything just in the last 12 months that was new will be reviewed here a little bit. I did want to give a little bit of background here since it is a specific disease state as opposed to the oncology that had numerous different cancers that we reviewed there. For glaucoma agents, approximately 2.7 million people in the United States suffer from glaucoma. It's the second most common cause of permanent blindness in the U.S. and most common cause of blindness among African Americans and Hispanics. Risk factors for the development of glaucoma include elevated IOP, advancing age defined as greater than 40 years, family history, and African American or Hispanic descent. Increased IOP is common in glaucoma and is believed to contribute to the damage of the optic nerve, which can lead to loss of visual sensitivity in field. However, some patients with glaucoma have normal IOP, and many patients with elevated IOP do not have glaucoma. So therefore, IOP alone is no longer considered a diagnostic criterion for glaucoma. 2 major types have been identified: open angle and closed angle. In open angle, there's reduced flow through the trabecular meshwork. Open angle accounts for the majority of the cases that you see. And in closed angle, the iris is pushed forward against the trabecular meshwork, blocking fluid from escaping. Reduction of IOP may be achieved either by decreasing the rate of production of aqueous humor or increasing the rate of outflow of aqueous humor from the anterior chamber of the eye. And topical ocular hypotensive agents can delay or prevent the development of primary open-angle glaucoma in some patients. So moving on to the next slide here, the only kind of newer thing to highlight for the committee is for the medication Durista. So in March 2020, the FDA approved a new formulation of Durista, which is the Matoprost implant indicated for the reduction of intraocular pressure in patients with open-angle glaucoma or ocular hypertension. The warning and precautions here, again, the highlight, the bolding indicates new information. Since we do have a little bit of time, I figure I can be comprehensive here. With warning and precautions, there is endothelial cell loss. So due to the possible corneal endothelial cell loss, administration of this medication should be limited to single implant per eye without retreatment. There's corneal adversion reaction, which has been associated with adverse reactions and risks with multiple implants. Using caution in patients with limited corneal endothelial cell reserve. And lastly, iridocorneal angle, and this medication should be used with caution in patients with narrow angles or anatomical angle obstruction. For dosage, it is an ophthalmic intracameral administration, and it should be carried out under aseptic conditions because it is an implant. And it is, like I said, an implant containing 10 micrograms of bimatoprost in a drug delivery system. This medication has not been established in pediatric patients, and there's no adequate or well-controlled studies for patients who are pregnant wanting to receive this medication. It's a shorter presentation for the glaucoma agents, but I'll pause here and ask if the committee has any questions.
Thanks, Umang. Just making sure, committee, any questions? Okay, I don't see we have any stakeholders listed. Is that correct?
This is Lita. That is correct. And I do not see that anyone is raising their hand. If you would like to speak, please raise your hand now. I don't see any stakeholders.
For efficiency, or I don't know if this is too confusing, is it all right if we review the immunomodulators and do both motions at the end? Or is it better if we do the motion now, Lita?
I believe the motions are split out, so. Oh, no, I'm sorry, they are together. Okay, so let's do the immunomodulators.
Okay, great.
Okay, so this is the first time we're kind of doing this for Washington State. There are no updates for immunomodulators in the last year, so there is no background information or anything or new medications to review. Again, the TCRs are posted for the committee members if they wanted additional information.
Okay, that's also very simple today. Are there any stakeholders? I don't see any listed, just confirming.
Yeah, there are still no one raising their hand.
Okay, so let's go ahead then and we'll do both of these motions. And again, committee members, chime in if we're moving too fast through any of these slides, okay? Okay, why don't you advance to slide 8, Lita?
If the committee's ready, can you all hear me?
Yes.
I move that, this is Diane Schwilke, and I move that all products in the drug classes listed on slide 6 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in these classes may require prior authorization to determine medical necessity. All non-preferred products require a trial of 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Connie Nguyen. This is Connie Nguyen. I second.
And all those in favor?
Aye.
Aye.
Are there any opposed? Okay, the motion carries.
This is Lita. Since we're just at 11:30, should we continue with the respiratory agents?
Yes, please. Let's keep going.
Okay, so we'll pivot over to the respiratory agents, specifically pulmonary fibrosing agents here. Again, to give a little bit of background here. So idiopathic pulmonary fibrosis, or IPF, is a chronic progressing lung disease occurring primarily in middle-aged to older adults. It's characterized by progressive fibrosis resulting in decreased ventilation and gas exchange. So in the US, it's estimated roughly about 132,000 people, with approximately 50,000 new cases being diagnosed and over 30,000 deaths per year. Researchers expect this number to rise due to improvement in accurate diagnosis and longer life expectancy as disease understanding and management increases. While the cause of IPF is unknown, a primary theory of pathogenesis is an inciting factor in a susceptible patient that may cause the initial alveolar damage, provoking a response ultimately leading to fibrosis. Potential risk factors for IPF include smoking, GERD, diabetes, viral infections such as Hep C. Possible causes of pulmonary fibrosis include environmental toxins, medications, and genetic predisposition. And most commonly, death is due to respiratory failure, but other causes include pulmonary hypertension, heart failure, pulmonary embolism, not edema, pneumonia, and lung cancer. Moving along to the medications, there are no updates and guidelines or anything like that. Again, more information is found in the TCRs in the web portal. So the medication OFEV, in September 2019, there were multiple updates to this medication. In September 2019, FDA approved expanded indication to slow the rate of decline in pulmonary function in patients with systemic sclerosis-associated interstitial lung disease, or SSC-ILD. And in March 2020, the FDA again approved a new indication for the treatment of chronic fibrosing interstitial lung diseases with a progressive phenotype. It already had, as you can see, it already had a previous indication for idiopathic pulmonary fibrosis. For this medication, in terms of warning and precautions, there is one for hepatic impairment, where this medication is not recommended for use in patients with moderate or severe hepatic impairment. There can be elevated liver enzymes, which kind of ties into the previous notation here, and drug-induced liver injury. So LFTs such as ALT, AST, bilirubin elevations have occurred, including cases of drug-induced liver injury. And lastly, prior to treatment initiation, it is necessary to conduct a liver function test in all patients and a pregnancy test in females of reproductive potential. I'll touch base on that in a minute. In terms of dosage and availability, you can see here, there's no update to that. This medication, in terms of pediatric patients, the safety and efficacy has not been established. In terms of pregnancy, which I was speaking of a second ago, based on findings from animal studies and its mechanism of action, it can cause fetal harm when it administered to pregnant women, and has a category D as in Delta right now for pregnancy. Something unique to note with this medication is particularly with patients who are smokers. So smoking was associated with a decreased exposure to OFEV, which may alter the efficacy profile. So it is encouraged for clinicians to instruct patients to stop smoking prior to treatment of this medication. This is the one and only update to the idiopathic pulmonary fibrosis class. I'll pause here for any questions from the committee.
Thanks, Umang. Any questions, committee members? Okay, I see one stakeholder, Michael Horton with Boehringer Ingelheim Pharmaceuticals. So Michael, when you're unmuted and ready, you'll have 3 minutes to share.
Everybody hear me?
Yes, can. Thank you.
All right, thank you. Good afternoon. My name, or good, actually in your case, I guess it's still good morning. My name is Michael Horton. I'm a Senior Associate Director for the Clinical Development and Medical Affairs team for the Interstitial Lung Disease Program at Boehringer Ingelheim. As you know, in September of this year, as he just pointed out, or September of last year, as was just pointed out, OFEB was indicated to slow the rate of decline in pulmonary function in patients with systemic sclerosis associated interstitial lung disease based on the efficacy in a phase 3 randomized double-blind placebo-controlled study of 580 patients who had systemic sclerosis interstitial lung disease. And this trial included patients with both diffuse cutaneous and limited cutaneous systemic sclerosis. The primary endpoint was the annual rate of decline in FVC over 52 weeks, and it was significantly reduced by 41 mLs compared to placebo, which corresponded to a relative treatment effect of 44%. The most common adverse event was diarrhea, which was reported in 75.7% of patients in the OFEB group compared to 31.6% of patients in the placebo group. Then in March of this year, we did receive approval for the treatment of chronic fibrosing interstitial lung diseases in patients with a progressive phenotype again, based on a phase 3 randomized double-blind placebo-controlled trial of 663 patients. I'm also meant to note in the package insert, this is referred to as study 5. The trial for the systemic sclerosis interstitial lung disease is referred to as study 4 in the package insert. This trial is a little bit different in that the inclusion criteria included patients with a clinical diagnosis of chronic fibrosing interstitial lung disease based on the presence of fibrosis on their HRCT and who presented with signs of progression, which was defined by a worsening of PFTs or a combination of worsening of PFTs, worsening of imaging, or worsening of symptoms. In addition, patients were required to have progressed despite management deemed appropriate in clinical practice by investigators for the patient's relevant interstitial lung disease. And this progression and treatment had to occur in the 24 months prior to randomization for the trial. Now, I did want to note that the underlying clinical interstitial lung disease diagnosis represented in the trial included hypersensitivity pneumonitis, autoimmune interstitial lung disease, idiopathic nonspecific interstitial pneumonia, unclassifiable idiopathic interstitial pneumonia, as well as some other interstitial lung disease. However, it should be noted that this indication is not based on an underlying interstitial lung disease, but is based on a phenotype, and that phenotype being people who have a chronic fibrotic lung disease that is progressive in nature. Similar to other trials, the primary endpoint was the annual rate of decline in FVC over 52 weeks. And in this instance, it was a reduction of 107 mLs, representing a 57% relative reduction. And then in terms of adverse effects, everything we saw was similar to what we've seen in the earlier trials with IPF and systemic sclerosis. So I realize 3 minutes is a short period of time, and that was a very brief overview. But if there are any questions, I'd be happy to answer those.
Thank you very much. Any questions from the committee? Okay, thank you. Are there any other stakeholders that we weren't aware of?
This is Lita. I don't see any other stakeholders.
Okay, thanks. Let's go ahead and move to the motion then for pulmonary fibrosing agents. Okay, I think you're okay to advance to slide 10.
This is Alex Park. Can I ask a question, Donna? Well, can I clarify? Can I ask you a question, Donna?
Sure, go ahead.
These are probably pretty pricey drugs, and it's in a very difficult condition that has pretty chronic progressive decline for most folks. And the data is kind of not super elevating for either of them. And you have a meta-analysis I was reading in the TCR that Umang provided. It's pretty old, and both drugs are pretty similar. So, I mean, how would HCA decide which drug gets to be preferred in a setting like this?
It's a great question. Usually, if the data is relatively poor on both of them and one doesn't kind of like rise to the top of as being more effective, we would usually look at the cost. I'm not 100% sure off the top of my head what our current status is on these particular drugs, so I'd have to look that up. So hang on, give me a minute.
Hey Donna, this is Marissa. Both the Esbriet and the OFAB are preferred EA on the PDL.
Oh,
Great, thank you.
that's very generous. That's great.
Are you recommending that we do something differently?
No, I was just,
okay.
We're ahead of schedule, and I was just curious how that works. I've had a couple of patients on these drugs, and they are extremely expensive. So I was just curious how HCA handles that, but it's nice that they've made the decision for the time being to make both of them preferred. Well, if the committee's ready, then I move that all products in the respiratory agents, pulmonary fibrosing agents drug class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Diane Schwilke, I second.
All those committee members in favor, please say aye.
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 Are there any opposed? Okay, the motion carries. And I would propose that we continue to move forward and do smoking deterrence before lunch.
Absolutely. So this is Umang again. I'm just bringing my camera up. Smoking deterrence is similar to the immunomodulators. So there are no updates in guidelines or new medications, formulations, or anything like that in this class. So there ultimately is nothing new to review in this class. So I'll pause here for the committee as well.
Thanks, Umang. We have one stakeholder, and that's Piao Ching with Pfizer. Piao, when you're ready to go, you'll have 3 minutes.
Good morning. My name is Piao Ching. I'm a pharmacist with Pfizer Medical Affairs team. I want to thank you for allowing me to provide information about Chantix in support of Pfizer's request to retain Chantix on Apple Health preferred drug list. Chantix is indicated as an aid to smoking cessation treatment in adults. The recommended dose of Chantix is 1 milligram twice daily, following a 1-week titration of 0.5 milligram once daily on days 1 to 3, followed by 0.5 milligram twice daily 4 to 7. The following information pertains to recent guidance related to smoking cessation. The 2018 ACC Expert Consensus Decision Pathway on Tobacco Cessation Treatment is applicable to anyone who smokes tobacco cigarettes, but it gives special emphasis to individuals with cardiovascular disease. Cigarette smoking is a chronic relapsing substance use disorder caused by addiction to nicotine. Most smokers have passed through repeated cycles of short-term abstinence, followed by relapse to smoking before achieving a long-term tobacco abstinence. This requires clinicians to adopt a chronic disease management strategy similar to other diseases such as hypertension and diabetes. All patients should be asked about tobacco use at all clinical encounters, and smokers should receive a clear advice to stop tobacco use. every smoker should be offered treatment rather than asked if they are ready. All smokers should be offered proven pharmacological smoking cessation aids and proactive connection to evidence-based behavioral support. Any opt-out models allow clinicians to offer smoking cessation treatment to every smoker, with patients having the option to refuse treatment. The 2018 ACC Expert Consensus Decision Pathway recommends Chantix as a first-line pharmacotherapy option for smoking cessation. The American Thoracic Society, or ATS, Clinical Practice Guidelines on Initiation of Pharmacologic Treatment in Tobacco-Dependent Adults was released on July 15 of this year. The guidelines do not address all possible pharmacotherapeutic options and do not address all potential clinical circumstances. The guidelines are not intended to supplant clinician judgment. Two key recommendations include the following. For tobacco-dependent adults in whom treatment is being initiated, Chantix is recommended over nicotine patch and over bupropion. In tobacco-dependent adults who are not ready to discontinue tobacco use, it is recommended that clinicians begin treatment with Chantix rather than waiting until patients are ready to stop tobacco use. In closing, I would like to thank the committee for listening to my testimony and again ask you to consider Pfizer request to retain Chantix on Apple Health preferred drug list. I'll be happy to respond to any questions you may have. Thank you.
Thanks very much. Are there any questions from the committee? Okay, thanks again. And just confirming there are no other stakeholders.
This is Lita. No, there are no others.
Okay, and we'll go to the motion then for smoking deterrence. And it's okay to advance to the next slide. This is Jenny Bucola, and I'll go ahead and make the motion if that's okay. I move that all products in the smoking deterrence miscellaneous - other drug class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization for medical necessity. All non-preferred products require a trial of 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Connie Nguyen, and I second.
And this is Jenny Bucola again. All those in favor, please say aye.
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 Any opposed? And the motion carries. And that brings us to the end of, it seems like a good pausing point for lunch. We're right at 11:48. So why don't we come back in 32 minutes to continue our afternoon. Is that okay?
12:20.
12:20. Okay, thanks everyone.
Thank you. This is Lita. I'll leave the meeting up so you don't have to log out.
Thank you.
Hi, Ginny, are you on the line?
Yes, I'm here.
Okay, great. Let's get started again. And I just have a note really quick that you can delete Shirley Quach from the stakeholder list for cytocam and CAM.
Okay. Got it.
Okay, great. And Marissa, are you on?
Hey, Lita, yes, I'm here.
Okay, great. I'm going to change presenters to Marissa, and she's going to go through the policies.
Okay.
Thank you.
Let me just make sure I'm sharing the right screen. 1 second. Okay. Can you see the cytokine and CAM policy up on the screen?
Yes.
Okay, great. Okay. So we can go ahead and get started with the cytokine and CAM antagonist policy. So Ryan Takatomo will be going through it. And then Ryan, I'll be guiding you. So if you need me to scroll down or switch to the form, just let me know.
Hi, this is Ryan Takatomo. Thanks, Marissa. All right, so starting off this afternoon with the cytokine and CAM antagonist policy. This is the third iteration of the policy. And so again, kind of to summarize, the purpose of this policy was to provide coverage criteria for the more common indications which these agents are prescribed in the Apple Health population. Key changes from the previous version include update to the drug list to incorporate new drugs to market, updates to the dosing and quantity limits, and we did update an age limit for uveitis. In addition, based off stakeholder feedback, we did add a new clinical indication for non-radiographic axial spondylitis. If you could scroll down to that section, please. Okay, thanks. So based off feedback, they requested that this indication be included. This indication is treated similarly to the ankylosing spondylitis. So the criteria is almost 100% the same as that. That comes from the American College of Rheumatology guidelines. You will note one difference with criteria 2C. With ankylosing spondylitis, we require trial and failure of both of our preferred products, which are Humira and Enbrel. However, for the non-radiographic axial spondylitis indication, we are only including Humira, and that is because only Humira is currently recognized in Micromedics, which is a recognized compendia for Medicaid. So other than that, the criteria for NAS or non-radiographic axial spondylitis will be the same as ankylosing spondylitis. Okay, if we could scroll down to the dosing and limitation section, just to point out that I did recognize that there are two new agents for which the non-radiographic axial spondylitis indication is not included. Currently it's included for Humira and Cimzia. However, Cosentyx and Taltz also have that specific indication. So the plan is to add those after the DUR meeting. And with that, we can move down to the PEND form. So this is the PEND form, which we send to providers that request the information, kind of facilitate the prior authorization process. And pretty much the only change was the addition of the non-radiographic axial spondyloarthritis indication. So with that, I'll leave it up to the committee to see if there are any questions.
Thanks, Ryan. Anybody on the committee have any questions? Okay, then we'll go ahead and move to stakeholders. We have 3 stakeholders: Carrie Johnson with Amgen, Bobby Bentz with Eli Lilly, and Bob Reemps with UCB. And so Carrie, as soon as you're unmuted, you'll have 3 minutes to share your comments.
Okay, this is Carrie. Can you hear me okay?
Yes, can hear you.
Okay, perfect. Okay, thank you. Okay, so this is Carrie Johnson. I'm a pharmacist with Amgen Medical Affairs. Thank you for the opportunity to speak in support of Otezla, or Apremilast. Otezla was FDA approved in 2014 for the treatment of adult patients with active psoriatic arthritis, adult patients with moderate to severe psoriasis who are candidates for phototherapy or systemic therapy, and now in July 2019 for the treatment of oral ulcers associated with Behçet's disease in adult patients. Warnings and precautions include diarrhea, nausea, vomiting, depression, weight decrease, and drug interactions. Please see the full prescribing information at amgen.com for further information. Some important reminders about Otezla. Otezla is not a biologic, and recent published guidelines place it in a separate category. It is an oral small molecule that works intracellularly to inhibit phosphodiesterase 4. This is a unique mechanism of action, and it reduces the cell's production of pro-inflammatory cytokines and increases the production of anti-inflammatory cytokines, further distinguishing it from biologics. Importantly, Otezla has no black box warning and no requirement for pre-medication screening or laboratory monitoring. And as an oral small molecule, it does not induce the production of anti-drug antibodies. 4 key updates. There were 2 label updates for this past year. The first, in July of 2019, Otezla became the first FDA-approved therapy for the treatment of oral ulcers in adult patients with Behçet's disease. This is a rare, chronic, multi-system inflammatory disease that affects approximately 5 in 100,000 people in the U.S. Oral ulcers occur in more than 98% of patients and can be significantly painful and affect quality of life. In the phase 3 RELIEF study, Otezla demonstrated significant improvement versus placebo at week 12 in the number and pain of oral ulcers associated with Behçet's disease. The most commonly reported adverse events include diarrhea, nausea, headache, and upper respiratory tract infections. The second label update in this past year. Scalp psoriasis occurs in greater than 90% of psoriasis patients and is considered a difficult to treat aspect of psoriasis. In the phase 3 STYLE study, Otezla demonstrated significantly greater improvement in scalp psoriasis, scalp and whole body itch, and quality of life versus placebo at week 16, with improvements continuing out to week 32. Most common adverse events: diarrhea, nausea, headache, and vomiting. These data are fully published and were added to the label this year. The third update: long-term data is published now out to 5 years in psoriatic arthritis and over 3 years in psoriasis, and they show no increase in incidence or severity of adverse events and no new safety signals over time. Fourth update is recently fully published claims analyses data demonstrate that biologic-naive patients with psoriatic arthritis who initiated Otezla had switch rates similar to biologic users and significantly lower healthcare costs regardless of treatment switching. In summary, Otezla is not a biologic. It's placed in a separate category in recent guidelines. Otezla does not have a black box warning and has no requirement for pre-medication screening or laboratory monitoring, has no warnings or precautions related to infection or malignancy, and as an oral small molecule, it does not induce the production of anti-drug antibodies. Otezla represents an important oral, non-biologic option for your adult patients with moderate to severe psoriasis, active psoriatic arthritis, and now for oral ulcers associated with Behçet's disease. Thank you for your time, and I'll take any questions.
Thanks, Carrie. Any questions from the committee? Okay, we'll move to Bobby Bentz.
Hello, this is Bobby Bentz. Can you hear me?
Yes, we can. Thank you. Go ahead.
Excellent. I'm an outcomes and evidence liaison with Eli Lilly and Company, which manufactures Taltz, also known as ixekizumab. This is an IL-17 inhibitor. It was originally approved for the treatment of plaque psoriasis, but has since been approved for psoriatic arthritis and ankylosing spondylitis, and was most recently approved for pediatric psoriasis and non-radiographic axial spondyloarthritis. As you've reviewed this drug before, I really just wanted to take a moment to provide 2 updates of research that were completed since your last review. And first is the completion of a study called XORA-R. This was a randomized controlled trial comparing Taltz with Tremfya in patients with plaque psoriasis. In this study, Taltz showed superiority to Tremfya on the primary outcome measure, which was a complete clearance of skin lesions. The other update is the completion of a trial known as SPIRIT H2H, and this study compared Taltz with Humira in participants with psoriatic arthritis. In this study, Taltz demonstrated superiority to Humira on the primary outcome measure, which in this study was actually a simultaneous achievement of ACR 50, which is a 50% reduction in disease activity. And then similarly to the other study, a completion of skin clearance or a PASI 100 score. That's really all I wanted to share today briefly, and just thank you for letting us provide some of these updates. As we always kind of suggest to review the package insert for all the safety details, and I'm happy to try to answer any questions you might have or provide follow-up as needed. Thank you.
Thanks very much. Any questions from the committee? Okay, and we'll go to Bob Reeves.
Hi, this is Bob Reeves. Is the volume good?
Yes, we can hear you.
Okay, thank you. My name is Bob Reeves, and I am one of the medical outcomes specialists for UCB. And I want to thank the committee, to the Washington State Healthcare Authority, to present the significant PI updates to UCB sertolizumab Pergol, or Cimzia. Now, Cimzia was the first, and it's the only TNF alpha blocker FDA approved for the treatment of non-radiographic axial spondyloarthritis, or NR-AxSpA, with objective signs of inflammation. Cimzia received FDA approval for NR-AxSpA in March of 2019. Now, to summarize, NR-AxSpA is painful and debilitating inflammatory arthritis, predominantly affecting the spine or sacroiliac joints. And in contrast to AS, or ankylosing spondylitis, which patients have evidence of structural damage on X-ray, NR-AxSpA patients do not, but that burden of disease is similar. And additionally, NR-AxSpA affects equally a distribution between males and females. Now, the PI, which now includes this significant indication for NR-AxSpA, which is supported by the our clinical development program, AS006 and AS001. And the dosing for NR-AxSpA for Cimzia is 400 milligrams initially, and at weeks 2 and 4, followed by 200 milligrams every 2 weeks and 4 weeks. We also have data in the PI now that reflects our pharmacokinetic studies in women of childbearing age, which includes CRIB, which was a prospective post-marketing multi-center PK study, which evaluated placental transfer of Cimzia, describing negligible to low placental transfer from mother to fetus, and CRADLE, which was a prospective post-marketing study that evaluated the concentration of Cimzia and human breast milk, which found minimal transfer into the milk during lactation. The adverse drug reaction profile now reflects that study with NR-AxSpA, which the safety profile reflects similar results to patients exposed in the RA category and previous experience with Cimzia. I want to thank the committee for the time, and I'll answer any questions. Thank you.
Thank you. Any questions from the committee members for Bob? All right, thanks very much. Are there any other stakeholders?
This is Lita. There are no other stakeholders.
Okay, let's go to the motion.
Hi, this is Marissa. I have the motion up for the committee.
Thank you, Marissa.
We can't hear you, Leah.
This is Leah Marquette. I move that the Apple Health Medicaid program implement the clinical criteria listed on policy 66.27.00-3 as recommended.
This is Nancy. I second that motion.
All those in favor, please say aye.
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 This
Any
is Lita.
opposed?
Marissa, that's Nancy Lee.
Oh, yes, correct.
Okay, thank you. Are there any opposed? Okay, and the motion carries. And we'll move on to Apple Health Policy, hormone treatment for gender dysphoria, as soon as you're ready. Sorry, I'm just trying to save the slide. This is Marissa. Let me just pull it up real quick here. Okay. Okay, so good afternoon, everybody. This is Marissa from the Healthcare Authority, and I will be presenting the hormone therapy for gender dysphoria policy. Just to give you guys a little bit of background, I did work on this in collaboration with Luke, our other pharmacist. He'll be presenting his other policies as well. So if you hear him chime in on some things, don't be surprised. He did work on this policy with me as well. So just to give you guys, the committee, a little bit of background on the policy, how this policy came about was we had the testosterone policy, which was just recently approved in June at the DUR meeting. And we identified that this the testosterone policy did not address or give any guidance to our MCOs on how to address hormone therapy for gender dysphoria. So we thought it would be advantageous to create a policy that would be all inclusive of all the hormone therapies used, so testosterone, estrogen, and GnRH agonists into one policy and have it be the hormone therapy for gender dysphoria policy. So as we were working on this policy, we did consult with our internal nurse consultant who oversees the transgender program here at the Healthcare Authority, just to make sure that as we were drafting the policy, that it was aligned with our WACs that we have in place, and also that it didn't create any additional barriers for patients. We also consulted with a pediatric endocrinologist at Seattle Children's Hospital, and then as well as some providers at UW Medicine who specialize in transgender care. So we were able to collaborate with a lot of different people just because we want to make sure that this policy is not restricting any access or creating any barriers for patients to get their medication. So as we were drafting this policy, we did use the World Professional Association, or the for Transgender Health, the WPATH guidelines, as well as the Endocrine Society guidelines for gender dysphoria, and we modeled the criteria after those recommendations. So just to give you a little bit of background on the disease state, so gender dysphoria involves a conflict between a person's physical or assigned gender and the gender with which he, she, or they identify with. Gender dysphoria can cause individuals to experience significant distress and problems with functioning associated with the conflict that they experience between how they feel and think of themselves and their physical or assigned gender. So treatment of individuals with gender dysphoria varies between change in gender expression or body modifications, or also both. So for this particular policy in general, we're really only addressing really the change in gender expression, just because it's really only addressing the hormone therapy. It's not addressing any surgical modifications that patients can undergo. But for hormone therapy, it's pretty common for even patients that are wanting to do body modification to really undergo hormone therapy first and then do the surgical modifications. So it is a pretty common process for patients with gender dysphoria. And the hormone therapy that they can undergo is either masculinizing or feminizing. So masculinizing therapy includes medications that increase testosterone levels in the body, and that causes masculinizing changes to occur. Wow, I cannot speak today. And feminizing therapy is just the opposite. So that includes medications that will decrease the levels of testosterone in the body while also using estrogen to induce feminizing changes. So this policy also addresses puberty suppression. So for those adolescent patients that want to undergo puberty suppression, the most common way is using gonadotropin releasing hormone agonists, or for this sake, I'm just going to say GnRH agonists, to help suppress endogenous puberty. And usually those adolescent patients that do undergo GnRH therapy end up transitioning to using either testosterone or estrogen, depending on if they are identify as female to male or male to female. So
Just to go through the policy here, we broke it up into different sections. So we have the testosterone therapy in one section, the estrogen therapy in its own section, and then the GnRH agonist therapy in another section. So it's split out that way just for your reference. So just to go through some of the criteria for the testosterone and the estrogen are pretty similar. The only things that really differ are really the risks associated with those medications, and I'll point those out as I go through the criteria, but it's pretty largely the same amongst the two. So the criteria for testosterone would be a diagnosis of gender dysphoria as defined by the DSM-5. The patient identifies as female to male or non-binary. We got feedback from a provider to include the non-binary just because some patients that do undergo hormone therapy don't necessarily want to transition to, they don't identify as female to male, they identify as non-binary. So we included that to be all-inclusive. The next criteria is the patient has been informed of the irreversible effects, including the potential loss of fertility. Documented informed consent is given for the treatment of dysphoria. So the patients understand the treatment that they're about to undergo and they attest to being agreed to that. If the patient is less than 17 years old, informed consent was given by the parents or the legal guardian as applicable, and a pediatric endocrinologist or other clinician that's experienced in pubertal assessment has determined that the hormone therapy is appropriate for patients less than 17 years of age. The patient is not pregnant or breastfeeding. The patient's risk has been evaluated. So these are the risks that differ between the testosterone and the estrogen criteria. So here we have that they've been evaluated and treated if necessary for breast cancer, if they have evaluated hematocrit, untreated severe obstructive sleep apnea, uncontrolled or poorly controlled heart failure, if they've had a major cardiovascular event in the past 6 months, or unstable coronary artery disease. So if they meet all the criteria, then the request would be approved for 12 months, and then reauthorization criteria would just be the same criteria that I discussed above, and then that would just be approved for 12 months as well. For the estrogen criteria, it's pretty largely the same, like I said. The only thing that differs is this number 6 right here. So the risks are different, of course, with estrogen versus testosterone. So the risks for the estrogen therapy would be a history of breast cancer, venous thromboembolism. They've been evaluated and treated for that, cardiovascular disease if they have a risk for that, cerebrovascular disease, severe liver dysfunction, a history of migraines, and they've been evaluated or seen if they had any risk for prolactinoma. And then also this request would be approved for 12 months if they meet the criteria. And then the reauthorization criteria, this should actually be changed, and I will actually change it now because we don't have a 7th criteria, it should be 6. So if they meet all criteria 1 through 6, and if they do, it'll be approved for 12 months for estrogen. For puberty suppression or GnRH agonist therapy, the criteria is different than the testosterone and the estrogen criteria, so I'll just walk through it a little bit. So for, they of course have to have the diagnosis of gender dysphoria like above. For those that are at adolescents, the patients, they have to have documentation from the provider that the physical changes of puberty have arrived, so at least Tanner stage 2. And then also documentation that puberty is ongoing and they have not completed puberty or gotten to Tanner stage 5. For when we consulted with the Seattle Children's provider, they did tell us that those patients that are seen and they're less than 17 years old usually have to be followed up for mental health services. So we wanted to keep that included in the criteria. So for this one, it would be confirmation from a mental health professional that all the following are true, that they have coexisting social, medical, or psychological problems that have been managed to allow successful initiation of treatment. The client has sufficient mental capacity to make fully informed decisions, and the behavioral health provider specializes in the treatment of gender dysphoria in adolescents. The criteria also they've been educated about the possible adverse effects, of course, and then that they have informed consent was given by the patient and the parents so that they know exactly what their treatment regimen is going to be and know the risks and benefits of it. For GnRH agonist therapy in the treatment of gender dysphoria, I'm sorry, I should have separated that. The top criteria that I was just explaining is for puberty suppression, and the bottom criteria is for the treatment of gender dysphoria. So in gender dysphoria, it's just that the diagnosis is that, by the DSM-5, and that the patient identifies as male to female or non-binary. Typically, GnRH therapy is used for those patients that are transitioning from male to female. So we didn't put anything for female to male. And then the patient meets the appropriate meets the criteria that is above in the estrogen therapy. So that's just listed here, and you would follow the estrogen criteria above. So for those, the request would also be approved for 12 months if they meet all the criteria. And then for reauthorization criteria, it would be that they have a positive clinical response. So we would want to see if it's used for puberty suppression, if the puberty, if they're able to suppress the endogenous hormones, and then if it's used for puberty suppression, documentation of ongoing need, and then of course informed consent from the parents and the patient. And for the reauthorization, it would be approved for 12 months as well. So just going down here to the dosage and quantity limits. So it's a pretty comprehensive list. We wanted to make sure that we included all of the products that are actually being used in clinical practice right now, products that we have as preferred and non-preferred on the PDL. So this here is all the testosterone products that we've listed with their dosages. So we have injections, we have gels, we have patches, implants listed for the testosterone products. And then for the estrogen products, we have, of course, the estradiol tablets, the oral tablets. We have the estradiol transdermal patches, the estradiol injections. And then I believe we actually need to add the gel on here. That was some feedback that we got from a provider, so I apologize it's not on here, but I will make sure to add that into the estrogen section now that I think about that. So estrogen gel will be there. And then for GnRH agonist therapy, we have the hystrelin implants, the leuprolide injections, triptorelin, and goserelin injections and implants listed as well. And these are the coding for this policy, the HCPCS codes associated with some of the products. And then the references are here as well. And then I'll go ahead and move over to our authorization form. So one thing to note about how we plan to manage how this policy will be implemented is for this particular policy, because we don't really want to create more barriers for those patients that are undergoing hormone therapy for gender dysphoria, we thought it would be best to handle the request by what we call expedited authorizations. So what the expedited authorization will do will, at the point of sale, the pharmacist the pharmacy that's filling the claim will get like a rejection, and they'll put in one of those EA codes, and then it'll override the PA requirement if there are any PA requirements on the drug. The only caveat to that is that the EA codes will not override the preferred or non-preferred statuses of these drugs. So if the doctor is trying to request for a non-preferred product and they try to put in an EA code, the pharmacist tries to put in the EA code, it won't work, or they might get a rejection to try a non-preferred or to try a preferred product first. So there's a little caveat to that, just so that then we're still keeping in line with preferred and non-preferred products on the PDL. So this form that you're looking at here would pretty much be used for like those non-preferred products. just so that then we can make sure that it's being utilized correctly. So this is pretty much a regular authorization form that we have. It hasn't been tailored to the clinical policy. So it's pretty general questions that we're asking. Of course, the diagnosis, any alternatives.
Hey, Marissa, I'm so sorry to interrupt you. This is Amy. This particular form would actually only be used if the pharmacy was not aware that the client met the EA criteria.
Oh, got it. Okay. Thank you, Amy, for clarifying. I apologize for misspeaking.
No problem. Thank you.
No, thank you. So like I was saying, the authorization, the questions that we ask on here are pretty general questions. It's not anything too specific. So what were the outcomes? Is there any other prescribers, brand versus generic, if the patient has tried a generic and they have to get the brand name product, and then any justifying comments that any providers want to put in there, they can write in there. So this is the authorization form for it. So if any of the committee members have any questions, I would be glad to answer any, but I'll go ahead and hand it over to you, Ginny.
Well, Marissa, actually, this is Ginny, and I do have a question. It's about the section under puberty suppression. I think it was number 4C. And it was, yeah, there we go. It was laid out so clearly around, yeah, that one right there. So my concern about access is that it's very difficult to find a behavioral health provider who specializes in children and adolescents, period, especially for our, our citizens who live more remotely. To find someone who specializes in gender dysphoria is going to be pretty hard. I'm wondering about language that might be more inclusive to a behavioral health provider willing to consult with a specialty team, or I'm not sure. I'm not sure what your thoughts are as you guys developed that language.
Yeah, this has been, I would say the behavioral health component of this policy has been the hardest, I think, for us to draft, just because, like you said, we have examples of if, it's hard to get a provider, because we did get feedback from some providers that not necessarily all providers, even in adult care, require their patients to see a behavioral health specialist. So we were trying to think of how we should word it. And so I'm open to any feedback if you want to wordsmith it right now. We can definitely do that.
And I would say that would be standard of practice at the clinic, the FQHC that I work in, that does a lot of gender affirming care, does not, again, they do not predominantly do adolescents, but there are some that are on the cusp of adolescence or who still might meet these criteria. My thought would be, and I'm certainly really open to any other word ideas, would be a behavioral health provider with the capacity to address the impact of treatment in adolescents.
Sorry, can you repeat that one more time, Ginny?
A behavioral health provider who is able to address the impact of treatment for gender dysphoria in adolescents. Just so we don't have that limiter, because I think it's also going to be difficult to quantify who is a specialist and how did they, and then that's a whole nother layer of sort of paperwork.
Okay, so you think it would be better for us to add what you've recommended into one of the letters, or would you like us to reword C?
I would prefer rewording C, just so we remove the requirement that behavioral health provider be a specialist.
Okay. Sorry. Okay.
Thank you.
No, thank you for the recommendation. Yeah, this was I will admit, this was a very tough section for us to draft up because we were trying to figure out how exactly to word it. So any feedback is good feedback.
I think it looks really good, and it's a really challenging, it's very challenging to find balance. So no, thank you. Are there any other questions from any other committee members?
This is Alex Park. Thank you, Marissa. It's obviously a huge amount of research and a lot of guidelines out there. You've done an amazing job kind of incorporating all of it. I think it'd be kind of good for practitioners to have access to the policy because it sort of tells them exactly what to do. But I think the only thing I would think about adding is the monitoring component under the female to male and male to female gender dysphoria. For instance, like number 7 under the female to male section, all those health issues, the cancer, et cetera, very important, but maybe just something like patient's risk have been evaluated and treated and monitoring plan established for the following, et cetera. And that would be consistent with endocrine guidelines, endocrine society guidelines for monitoring for those conditions as well.
Okay. I'm just gonna wordsmith it right now because I like what you said. So
sure, yeah. Take care of it while we're on.
Yeah. So patient's risk has been evaluated, treated, and monitoring plan. Sorry, Dr. Park, could you just go ahead and repeat what you said?
Oh, well, sure. We could say like monitoring plan established.
Okay. Okay. How does that look?
That looks great.
Okay.
That looks great.
Okay. And I'll go ahead and add that to the estrogen section.
Super. Thanks, Marissa.
No, thank you for the feedback, Dr. Ford.
This is Lita. I have a question from Petra Eichelsdorfer. Sorry if I mutilated your name. There are some additional estrogen products that are not included in the list in the policy. For example, estradiol topical spray. Does the HCA intend for the list of products included in this policy to be inclusive of all that are currently available? And Petra, I'll unmute you if you want to follow up.
I'll go ahead and wait and see if, sorry, this is Marissa, if Petra has any questions. Otherwise, I can address.
Yeah. No, I just happened to notice, and I'm sorry I didn't notice this in earlier reviews, that there are some products out there that they're not used very often, and they're generally not preferred items, but there are other products that are not listed on there. And since that list is including quantity limits, and is likely to be interpreted as showing what products are actually coverable for gender dysphoria, the question arises, do you want to include those products as possibly coverable for this diagnosis?
Yes, so this is Marissa. That's a really great question, Petra. So we could definitely add it in, but we were thinking as we were drafting the policy of really only including products that are actually being used in clinical practice right now. I feel like that we thought that might make the most sense. So I mean, if I want to say the providers that we did speak to didn't make any mention of, I think it's the spray that you said, but I mean, if the committee, if you guys recommend I add it, or if you think it might be confusing to leave it off, I'm open to any suggestions that you might have.
Yeah, my suggestion would be if you want to focus just on products that are currently being used in clinical treatment, you add some kind of a statement about that. You know,
okay.
that other products are also coverable, and whatever caveats you want to have, because if we should, you know, because approach to treatment changes over time, and
right.
Our ability to change these policies is usually behind, you know, it lags a little bit behind, and that means we're going to get those requests potentially before the policy gets updated to include those products.
Got it. Yeah, I think that's actually a great idea to add like maybe a note there. Excuse me.
Yeah.
Yeah, noting that the products listed are clinical practice products, I guess, that are being used. And then as, you know, as things change, you know, we can certainly update it to include those other products in the policy.
Right, and then maybe some kind of a statement around quantity limits that you want to put on those products, or if you don't want to. I mean, there needs to be some guidance around how to handle a request for this diagnosis for a product that's not listed.
Okay.
Because as I said, ultimately we're going to see a request before the policy gets updated, just because of the way that these policies get updated.
Thank you, Petra. I'm making it now.
Right. And I apologize. I have to leave the conversation for a little bit for another meeting. So if you have any additional follow-up questions for me, if you can let me know later.
Okay, yeah, no problem.
Reach out to me via email.
Sounds great. Thank you so much.
Okay, thanks. Bye-bye.
So while Marissa's finishing that, I just want to open it back up to the committee and see if there are any other comments, and as well as you, Marissa, any other questions, specific questions for us?
Sorry, this is Marissa. I guess, do you guys think that would be a great idea, what Petra recommended about adding the statement for the products listed are clinical practice? Or I just want to see from the provider perspective if it would be confusing not adding those on, or if we should add them on. Just want to get that view.
Yeah, this is Nancy. I would suggest maybe saying products that are used in clinical practice based on current practice guidelines, like associated with the current practice guidelines. And so as the practice guidelines get updated, some of the products could be updated too, I guess.
This is Marissa. Okay, I'll go ahead and add that. Sorry, can you repeat that one more time? I'm just going to write that note in here.
But Nancy, I'm a little concerned about saying stuff like that, because clinical practice guidelines aren't necessarily based in evidence. They're not, unless we have a particular practice guideline that we like and feel is strongly based in evidence. I hate to have something out there that just says, in general, we'll follow clinical practice guidelines, because we all know there's lots of guidelines out there and they're not always supported in the evidence. And this is Donna, by the way.
What about changing it to like high quality clinical practice guideline? I mean, we kind of use clinical practice guidelines for other things too, and we've consulted specialists for this as well. So I don't know.
What are you trying to accomplish?
I guess used in clinical practice. So sometimes clinical practice and guidelines don't necessarily go hand in hand.
Yeah, I think we'll, I don't think we need to wordsmith this here. I think we can come up with a way to incorporate these new, these other agents in there. There's already a note that says if any drug, comes to market with a new indication that would fall under this policy, it would be covered for that indication. So we'll work on getting this addressed and making sure that it's clear that products that are indicated for this treatment or supported with compendia would be approved.
Okay.
Okay, do we feel ready to move to a motion?
Yes.
All right.
This is Marissa. Okay, I have the motion up for you.
This is Alex Park. I move that the Apple Health Medicaid program implement the clinical criteria listed on policy 24.00.00-1 as recommended.
This is Connie Nguyen. I second.
This is Jenny Bucola. All in favor, please say
Aye.
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 Any opposed? Okay, the motion carries.
This is Marissa. Connie, did I spell your last name correctly?
Yes, you did. Thank you.
Okay, perfect.
We're scheduled to take a break right now, but since we're moving so quickly, I will propose that we just keep on going and speak up.
Yeah, this is Lita. The break's actually scheduled for 1:45. So
okay.
Let's keep.
Thank you. I'm just looking in order, not the time slot. Thanks, Lita. So we'll go to the migraine agents, the CGRP receptor antagonists with Luke.
Okay, this is Marissa. I am pulling it up now. And Luke, whenever you're ready, just let me know when you want me to scroll down.
All right, thank you, Marissa. This is Luke. Can you guys hear me?
Yes, we can hear you.
Great. So good afternoon. The purpose of this is to discuss the new Apple Health policy regarding oral calcitonin gene-related peptide or CGRP antagonists. This policy highlights two medications that we did discuss earlier this morning, ubrogepant or Ubrelvy and rimegepant or Nurtec ODT. Both of these are indicated for the acute treatment of migraine headaches in adults. So background, and I apologize if this is a little bit of a refresher from Curtis's presentation earlier, but Ubrelvy was approved by the FDA in December 2019, and Nurtec was more recently approved in February 2020. Both agents were evaluated in very similar phase 3 randomized controlled trials that had included patients who had experienced between 2 and 8 migraine episodes per month for the preceding 3 months. Notably, a very large majority of these patients studied were women, which is reflective of the disease state, and had attempted other abortive treatment previously, most commonly NSAIDs. Both Ubrelvy and Nurtec ODT increased pain freedom at 2 hours and decreased bothersome symptoms, which included photophobia, phonophobia, and nausea compared to placebo. They did so in a statistically significant manner. One key difference between products is that Ubrelvy allows for a second dose 2 hours after the first dose, whereas Nurtec ODT allows for a single dose per 24 hours. So Marissa, if you could scroll down a little bit here, we'll discuss the clinical criteria very briefly. These are based primarily on the clinical trials and also the product labeling, and a high-level summary. I'll go through a high-level summary of these criteria, which include number 1, appropriate diagnosis of migraine. Number 2, at least 2 migraine episodes per month. 3 is there has to be an evaluation for medication overuse headaches. 4 is trial and failure of at least 2 triptans, including at least 1 triptan that is used in combination with an NSAID. And at this time, we wouldn't allow these oral agents to be used in combination with a preventive CGRP antagonist. And then finally, client is an adult or 18 years or above. And you could scroll down a little bit more to the reauthorization criteria, which mirror the primary outcomes studied in the clinical trials, and reauthorization would be allowed if effectiveness is demonstrated either by reduction in pain or reduction in bothersome symptoms. So you could keep scrolling down. Have the dose and quantity limits there, which notes that Ubrelvy may be used twice in a 24-hour period, Nurtec once, and then a brief evidence review below that. And then we can head down to the penned form as well for your review.
This is Marissa. Sorry, I'm just pulling it up right now.
Yep.
I think it's. Sorry, hold on, I'm having technical difficulties. I don't think I have it. Let me open it real quick. Okay, this is Marissa. It should be showing up now, Luke.
Great. So this is the form that the prescriber fills out to ensure that the prescribing aligns with the policy. And feel free to take some time to review it, and then I'm happy to accept any questions about this policy.
Thanks, Luke. Are there any, no, I called you. Yes, I called you. I got my names mixed up. I'm like, I called you Luke. No, you're Ryan. That's right. Thank you for that review. Any questions from the committee members? All right. So we're going to go ahead and move to stakeholders then. Looks like we have two stakeholders, Chelsea LaRue with Biohaven and Tim Wardell with AbbVie. So Chelsea, when you are unmuted, please go ahead with your 3 minutes.
Hi there, this is Chelsea LaRue from the Medical Affairs Department at Biohaven Pharmaceuticals with Nurtec ODT or Rimegepant. I just have a few comments to make in addition to the comments that I made earlier in the day. Regarding the dosage and administration, the reason for the maximum dose in a 24-hour period being that one single dose is due to the long half-life of 11 hours that Nurtec has. And in our clinical trials, we saw sustained benefits through 48 hours with a single dose. And then regarding the concomitant use of the gepants as acute migraine treatment with a CGRP monoclonal antibody or MAB for preventive treatment, there is no contraindication. And once those MABs were FDA approved, they were allowed as concomitant preventive medication in the 52-week long-term safety study with Nurtec. And two recently published analyses of this cohort of patients using Nurtec and either arenyumab, fremanezumab, or galcanezumab suggest that Nurtec may be used acutely to relieve attacks without tolerability or safety problems in those patients receiving preventive CGRP MABs. So I will stop there and answer any questions that you may have about Nurtec.
Any questions from the committee? Okay, thank you, Chelsea. And we'll move to Tim.
All right, looks like I'm unmuted. Similar to Chelsea, just a couple of key points, looking at the criteria one more time that would be different from what we discussed this morning. I wanted to make it clear, a key differentiation that we had in our clinical trials program was the outcomes assessed in those triptan naive, triptan contraindicated and non-responders in measurement of pain freedom and absence of most bothersome symptoms at 2 hours post-dose was that in addition, about 25 of the patients in our clinical trials program maintained their pre-enrollment preventive medication use while in the trial as well, out through the long-term safety study extension trial. As mentioned earlier, in the long-term safety study, no adverse or large or significant adverse events, which I know was a question earlier today, were to be found, particularly around LFTs, as that had been a measurement that precluded their approval about 5 or 6 years ago. So with that being said, I think we covered most of it this morning. I'd be happy to give my time back.
Okay, thanks, Tim. Any questions from the committee? All right, anyone, any other stakeholders that were not on the list?
This is Lita. I don't see any other stakeholders.
Okay, let's go ahead and go to the motion then.
This is Alex Park. Can I ask you a question, Luke?
Sure, yeah.
I was just looking at the reauthorization criteria. What are you looking for from providers when you say clinically meaningful reduction, as opposed to just reduction?
That's a good question. So I wanted to kind of purposefully leave it vague, just to provide access to the medication if the patient had reported basically any sort of pain reduction that improves their quality to a significant degree, then I wanted to allow them to try the medication again. Does that answer your question? And that's
yes.
Kind of what I meant by clinically significant or meaningful.
Yes, I mean, there's a whole field of how we define what is clinically meaningful in pain reduction in the literature, and it's a pretty hot topic, and sometimes it means certain severity scales or statistical mumbo jumbo was used to quantify what's happening. But so I think what you're saying is that's not what you're looking for, and I just wanted to make sure that we weren't limiting access by forcing providers to use one of those proscribed measuring sticks. Thank you.
Yeah, I just saying reduction in pain, I wouldn't be opposed to that. However, just saying reduction in pain doesn't necessarily mean that it's really improving anybody's quality of life. You can go from 10 to 9, still be.
Thank you. Donna, it's Alex Park here. I noticed on the other policy we're listing preferred, non-preferred, but we're not on this. Is that okay, and or is there a reason for that?
It's probably just an oversight that we would list. We just need to list which are preferred and non-preferred. Also, I think because we reviewed the drug class and there's new drugs, we might not have a complete list yet, but we'll get that added.
Okay, thank you.
Hey, Jenny, this is Marissa. Did you want me to move back to the motion slide? Thank you. Okay.
This is Alex Park. I move that the Apple Health Medicaid program implement the clinical criteria listed on policy 67.70.10-1 as recommended.
This is Leah Marcotte. I second the motion.
And all committee members in favor, please say aye.
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 Any opposed? And the motion does carry. And that will take us to our next topic, migraine agents that are calcitonin gene-related peptides, receptor antagonists, excuse me.
This is Marissa. Luke, it should be pulled up now. Let me know if you don't see it.
I can see it, thank you. This is Luke again, and I'll now be discussing an update to the Apple Health Apple Health policy regarding subcutaneous calcitonin gene-related peptide receptor antagonists for the prevention of migraine. This policy was previously published in 2019, and I'm seeking feedback or approval on a few updates. As far as preferred options go, the Emgality remains the preferred medication in this class. So first, for the minor updates, the primary indication for these medications remains prevention of migraine headaches. The clinical criteria for approval for this indication has remained similar, although there are a couple notable changes. And Marissa, if you could scroll down a bit to the clinical criteria for prevention of migraines. That's great right there. First, the ICHD3 diagnosis criteria was added to the appendix of this policy just for completeness and to provide a general reference for the diagnosis criteria. And then if I can draw your attention to criteria number 4, which discusses the medication classes that have to be tried prior to approval for these agents. We removed calcium channel blockers as an option. So now criteria 4 directs trial and failure of at least one agent from 2 out of the following 3 classes: anticonvulsants, antidepressants, and beta blockers. And that removal was because there's not great compendia support for use of calcium channel blockers in the setting of migraine prevention. So Marissa, if you could scroll down to the next page, to the preferred therapies section or table. Yeah, there we go. Calcium channel blockers is not listed there anymore. Under the antidepressants, nortriptyline was removed for similar reasons, and under beta blockers, timolol and nadolol were added. And then those are the minor updates to this policy. The largest update to this policy is the addition of a new indication, cluster headaches, for Emgality. So Marissa, I apologize, but you scroll up right there. Excellent. Emgality gained approval after demonstrating safety and efficacy in a phase 3 randomized placebo-controlled trial. In the trial, 49 patients taking 2 doses of Emgality 300 milligrams, 1 at baseline and 1 after 4 weeks, were compared to 57 similar individuals taking placebo. Each patient had between 4 and 8 headache attacks per day at baseline. During weeks 1 through 3, Emgality reduced headache frequency compared to baseline by a mean of 8.7 attacks per week compared to 5.2 attacks per week for placebo, which was statistically significant. One note that Curtis brought up this morning is that the benefit of Emgality did not extend to the 8-week mark. However, that could be because of the nature of cluster headaches as a disease state, where they often just spontaneously resolve after a month or so. So that could certainly be a factor here. So I'll provide once again a high-level summary of the clinical criteria for medication and approval, which includes again an appropriate diagnosis, Again, evaluation of medication overuse headache, and then trial and failure of an adequate verapamil dose, which is 360 milligrams daily. And then the patient has to be an adult, age 18 or older. Upon initial approval, a maximum of 2 doses of Emgality can be approved for cluster headaches, and it may be reauthorized with continued need, meaning that the cluster headache episode is still ongoing, and demonstration of effectiveness. And Marissa, you can scroll down, outlining the dosage and quantity limits. The dose for Emgality is different based on indication. And then there's the appendix has the diagnosis criteria for cluster headache and also migraine. And we can head on over to the penned form as well for the committee's review. Similar to before, cluster headaches were added as a possible indication. And please review, and I'm happy to answer any questions.
Luke, it's Alex Park here. There was one new drug that we elevated on our work at the P&T this morning. I'm trying to find the name. It's Epti something.
Right.
Help me out. Sorry?
The IV one.
The eptinizumab, is that it? Yes. Do we need to add that to the drug list on the policy?
That's a really good question, and I guess I would defer to Marissa and or Donna on that question.
Can you repeat the question? This is Donna.
This is Alex Park. I was just asking about the eptinizumab. We elevated that to be on interchange at the P&T earlier this morning, and wondering if we need to include it on the drug list for the Apple Health policy.
Yes. Well, I think this is for treatment of, was it one of the new ones for preventing chronic migraine or for treating? Because this is for prevention, this policy.
I think it was one of the preventive CGRPs.
Okay, so if it is one of the preventive ones, it would be added as non-preferred.
Okay.
Right, and I did check the Apple Health PDL on that drug, and I couldn't find it on there now.
And we'll look to see if it's in the drug file yet, if it's on the market yet or not. It might not have, depending on how new it is, it might not have gotten into the drug file yet.
Okay, thanks for checking.
This is Leah Marquette. This is very minor, but galcanezumab is misspelled later down in the policy a couple of times. It's lower. Lower. Right there in the second column. And then I think it's in the next column down too.
Oh, thank you.
Luke, this is Donna. There's another instance of the misspelling in the criteria for reauthorization as well.
This is Ginny, excuse me, this is Ginny, just chiming in to make sure committee members don't have any additional questions. Okay, thanks, Luke. We have one stakeholder, and that's Carrie Johnson from Amgen.
Hi, this is Carrie Johnson. Can you hear me okay?
Yes, we can. Go ahead.
Yeah, I provided the full testimony on Aimovig. I'm the pharmacist with Amgen Medical Affairs. I provided full testimony on Aimovig this morning, and I'll give back my time unless there's any questions.
Any questions? Okay, thanks very much, Carrie. Any other stakeholders?
This is Lita. I don't see any other stakeholders.
Okay, then why don't we go ahead and go to the motion? Oh, there you are. You're so fast, Marissa.
This is Leah Marcotte. I move that Apple Health Medical Program implement the clinical criteria listed on policy 67.70.20-2 as recommended.
This is Alex Park. I second.
This is Ginny Bucola. All in favor?
Aye.
Aye.
And are there any opposed? Okay, the motion carries. And we will move to antipsychotics, the second generation, specifically Vraylar, with Ryan Takatomo.
This is Marissa. Sorry, I'm just going to pull it up quickly here. So let me know, Ryan, if you can't see it, but I should be presenting.
Hi, it's Ryan Takatomo. I can see it. Thanks, Marissa. All right, so this policy will specifically be for Vraylar, a second generation antipsychotic, and the purpose of this policy is to ensure appropriate use given the number of agents in this class. So moving down to the clinical criteria, criteria is pretty much the same throughout the 3 indications listed. Common ones being that the client is 18 years or older, that they meet one of the following. For number 2A, that would be a trial and failure of 3 of the listed oral atypical antipsychotics, or that there's documentation that the client has been taking Vraylar and is stabilized on the request dose. Criteria number 3 being that they have adequate renal function, and criteria 4, scroll down, should be no history of liver disease or no severe liver disease. Differences between the indications mainly revolve around the agents which are listed in criteria 2A. So that would be the main difference between each of the indications, and I would recommend reviewing that list. Other than that, the initial authorization criteria is fairly consistent throughout, and the same applies to the reauthorization criteria. Okay, and after that, it's pretty much just the dosing and limitation section for Vraylar. And then we have the PEND form, which again sort of facilitates the prior authorization process. And with that, I'll give the committee some time to review the policy and the pen form. And if they have any questions, feel free to ask.
Thanks, Ryan. Any questions from the committee? Okay, we'll go to stakeholders, and we have two. We have Philip Jennings with AbbVie and Paul Thompson with Alkermes. And so Philip, as soon as you're unmuted, feel free to take your 3 minutes.
Hi, good afternoon. Can you hear me okay?
Yes, we can.
Great. Well, my name is Philip Jennings. I'm a senior medical science liaison with AbbVie, and thanks for the opportunity to briefly review Vraylar with you today. It's indicated for schizophrenia in adults and treatment of manic, mixed, or depressive episodes of bipolar I disorder in adults. It has box warnings regarding suicidal thoughts and behaviors and increased mortality and dementia-related psychosis, and as well as the same warnings and precautions as the other atypical antipsychotics in the class. I'm not going to have time to review all those today, so please refer to the PI for that. The most common adverse effects are akathisia and extrapyramidal symptoms, so discontinuation due to these side effects was about 2% or less in the registrational studies. I'd like to address the challenges presented by your current proposal to require 3 steps through other antipsychotics before allowing Washington Medicaid patients to receive Vraylar. This policy would place some of the most vulnerable patient populations at risk by requiring prescribers to use some medications that have not been proven safe and effective for these populations prior to using FDA-approved Vraylar. Specifically, the bipolar I disorder mixed or manic episodes category has a branded drug, lurasidone or Latuda, as a potential step before Vraylar. However, Latuda is not FDA approved for this indication. In the depressed bipolar I disorder category, olanzapine is listed as one of the 3 steps. However, as monotherapy, olanzapine is also not FDA approved for this indication. This should be of concern to the committee, the mental health prescribing community, as well as, and most importantly, to Washington residents. Vraylar does have several characteristics which distinguish it from other drugs in this class. First, while the precise mechanism of action is unknown, Vraylar is unique amongst atypical antipsychotics, having the highest affinity for the dopamine D3 receptor, and it's the only D3 preferring antipsychotic available. Activity of the D3 receptor is thought to be beneficial for mood and cognitive deficits, and that's one reason it's used. Second, Vraylar has the longest half-life of the orally available antipsychotics, and this long half-life suggests that there may be some continued effect that persists after discontinuation of Vraylar, and this may be beneficial in preventing rapid onset of relapse in cases of intermittent adherence. Then finally, Vraylar has a neutral metabolic profile and minimal risk of weight gain and sedation, which is common to some of the other antipsychotics that are required steps for a Washington Medicaid patient to receive Vraylar. Vraylar is unique in its class with the highest affinity at the D3 receptor. The long duration of effect and the good tolerability profile are also potential benefits. Vraylar is one of only 2 monotherapies that are FDA approved for the treatment of the full spectrum of bipolar I disorder, including manic, mixed, and depressive episodes. And it's the only treatment for the full spectrum of bipolar I disorder that is considered metabolically neutral with minimal risk of weight gain and minimal sedation. Prescribers choose Vraylar to treat some of their most complex patients for many of the specific reasons I've mentioned here. Vraylar is commonly not a first-line drug for bipolar or schizophrenic patients, and many Medicaid programs recognize this by requiring only a single or a double step. Requiring these additional steps in front of Vraylar makes it difficult for your mental health providers to provide the best possible care for their most vulnerable patients. Thank you for your time and attention. I appreciate it.
Thanks very much. Any questions from the committee? Okay, we'll move to Paul Thompson.
Hi, can you hear me?
Yes, we can. Go ahead.
Oh, great, thank you. So my name is Paul Thompson. I'm a psychiatric pharmacist and senior medical science liaison at Alkermes. Thanks for the opportunity today to provide testimony on Aristada Initio, which was approved in July of 2018. It is an extended release injectable suspension for intramuscular use. I'll highlight a few clinical points today. First, Aristada Initio has a black box warning for increased mortality in elderly patients with dementia-related psychosis. I'll refer you to the full PI for complete box warning and additional info on those. Aristada Initio, along with a single 30 milligram oral aripiprazole dose, is part of a one-day initiation regimen given in conjunction with the first dose of Aristada and is indicated for the initiation of Aristada when used in the treatment of schizophrenia in adults. The main formulation difference between Aristada and Aristada Initio is the particle size of the aripiprazole Laroxyl crystals in the injection suspension. where Aristada is comprised of micron-sized particles that's chosen for slow dissolution, is approved for monthly, every 6-week, or every 8-week dosing intervals. Aristada Initio has much smaller sized particles in the nanometer range, and after injection releases aripiprazole faster than Aristada and is only to be used as a single dose. The smaller sized particles of Aristada Initio reduce the time to achieve therapeutic levels of aripiprazole relative to Aristada. The 1-day initiation regimen can be used to start with any dose of Aristada, including the 2-month dosing interval. Aristada Initio is only available in a single strength, 675 milligrams, and is only used as a single dose and not for repeated dosing, and it is not interchangeable with Aristada due to the differing pharmacokinetic profiles. Aristada Initio is administered intramuscularly by a healthcare professional in the deltoid or gluteal muscle. For patients who have never taken aripiprazole, tolerability should be established with oral aripiprazole prior to initiating Aristada Initio. Aristada Initio should be avoided in patients with known CYP2D6 poor metabolism or concomitant strong 2D6 3A4 inhibitors or inducers, or with antihypertensives or benzodiazepine. This is because there are no dosage adjustments available to Aristada Initio since it's a single dose. The only contraindication is hypersensitivity to aripiprazole, and in pharmacokinetic studies, the safety of Aristada Initio was generally consistent with that observed in Aristada. Aristada Initio is available in a pre-filled syringe and does not require refrigeration. It should be restored at room temperature and not frozen. In closing, Aristada Initio alongside with a 30 milligram dose of oral aripiprazole is part of a 1-day initiation regimen given in conjunction with the first dose of Aristada, and is an option for patients to the previously approved 21-day oral initiation regimen. The 1-day initiation regimen provides comparable plasma concentrations to the 21-day oral initiation regimen. And although Aristada and Aristada Initio are both suspensions containing the same molecule, aripiprazole Laroxyl, the drug particle size of Initio is smaller, and therefore the formulations are not interchangeable. I would like to thank the committee for the valuable time today, and also respectfully request you consider adding Aristada Initio to the Washington State Preferred Drug List. Does the committee have any questions for me?
Thank you, Paul. Any questions, committee members? Okay. All right, it looks like we will go ahead and move to our motion. Oh, just to double check, there were no other stakeholders, I believe.
This is Lita. There's no other stakeholders.
Okay, and we go ahead.
I have one question. If we can move back to the policy, there's wording around the patient doesn't have cirrhosis or child Q score is okay. I just wanted, that makes sense to me. So if the patient does have cirrhosis, I just wanted to look at that again just to make sure it was correct. Thanks.
Any other questions, Alex?
This is Alex Park. Can I ask why we chose to limit the access to Vraylar versus some of the other second-generation antipsychotics that are listed? I've just been looking at some of the data, and it's actually quite convincing medication, certainly compared to aripiprazole and some of the others that are needed to be tried first. So I just wanted to understand the thinking behind that.
Hi, it's Ryan Takatomo. I will probably have to defer that one to Marissa or Donna.
State that one more time.
This is Alex Park. I was just asking why we're singling out Vraylar in this policy as second line as opposed to other drugs in the same class.
Great question. I'm thinking it's just one of the brands that is still out there. I'm wondering if it has a different definition. Alex, that's a very good question.
Hi, this is Marissa. So the reason why this policy is just Vraylar by itself was because the other products that are listed are pretty much preferred with really no FDA restrictions on them. Vraylar is the only one, I believe, that has a PDL, which is medical necessity, and we have high utilization of particular product. So we don't really have a policy, so I thought it would be best for us to get a policy to provide some guidance.
Marissa, this is Jenny. I'm sorry, but you, your voice was breaking up a little bit, and I was curious to hear what you had to say. I don't know if you could try to say it again.
Yeah, hi, this is Marissa. Do you hear me better?
Yeah.
Okay. So the reason why VRAILAR has its own policy instead of it being like a class-wide policy was because the other products in the class pretty much prefer no restrictions to PA. But right now, VRAILAR has a PA requirement on it for medical necessity. So we just needed to create a policy because there's a high utilization for it. So it provided some guidance for authorization staff and the MCOs on how to approve or deny this medication.
This is Jenny, just adding a comment as a psychiatric prescriber. While I don't personally have a lot of experience with VRAILAR, since I primarily work with people who receive their insurance through the state, and I would say that among my colleagues it would be more standard to use an agent that has a few more road miles on it. That I lost my train of thought. I had something to add that I thought would be helpful to our discussion, and I got sidetracked. I do want to say that I think if somebody were medication naive and presenting to me, that as long as I have access to metabolically neutral agents, I would prefer to keep somebody on an agent that is generic, so that if you needed to pay for this out of pocket for whatever reason, they would have the option of using a generic option first. Not to say that this agent isn't appropriate at times or won't become more, as it becomes more accessible, won't be more useful. So that's just a comment from practice.
Hi, Jenny, this is Marissa. Yeah, thank you for that comment. The reason why it does have PA is because there's so many other generic antipsychotics on the market. So that's really the reason why, the PA, and we want to make sure that it's being used for the right indication.
Any other questions? Are we okay to move to the motion? Okay, we could go ahead and bring the motion up then.
This is Jordan Storhaug. I move that the Apple Health Medicaid program implement the clinical criteria listed on policy 5940-018-1 as recommended.
This is Leah Marquette. I second that motion.
And this is Jenny Bucola. All in favor?
Aye.
Aye.
Any opposed? The motion carries. And I'll pause briefly. We're at 1:51. We're scheduled for a break, but we also only have 2 more topics to cover. So I propose we continue to move on unless there's any need to take a pause.
This is Nancy Lee. I second that motion to continue forward.
Lita, is there any need for a break right now?
Nope, we can keep moving.
Okay, let's go back to Ryan for gout agent.
This is Marissa. Ryan, it's ready whenever you are.
Thanks, I can see it. This is Ryan Takachemo. So this will be the first presentation of a policy for gout agents. It contains agents for both the flare-up and then the urate lowering. And the purpose of this policy is, of course, to ensure appropriate use of the agents included in this policy. So if we could go down to the first clinical criteria. Okay, so this is for colchicine, specifically Gloperba, which is the oral liquid formulation of colchicine. And so ultimately, we just want to make sure that first, that colchicine is being prescribed appropriately and safely, and that there is some particular reason on why the liquid is being prescribed versus the tablets or capsules which are available. Okay. And reauthorization criteria just wants to make sure that that status that the patient can't take the capsule and tablets is continuous. The next drug is febuxostat or Uloric. This is a urate lowering medication, and the purpose for some of these clinical criteria is to ensure that other more cost-effective agents have been tried prior to the use of this medication, primarily medications such as allopurinol. This medication also has some cardiovascular adverse events potentially, so some of the criteria included reflect that, and just want to make sure that both the patient and prescriber are aware of those cardiovascular risks. If we can move to the reauthorization criteria, please. And so with the reauthorization criteria, we just want to make sure that there's a documented positive response when using this medication, and that the patient has not experienced any cardiovascular events. Okay, and then the second urate lowering agent is Krystexxa or pegloticase. Similar to the Uloric criteria, because of the cost for this drug, we do require prior use of Uloric before this medication can be accessed. Other than that, a lot of the criteria is the same as Uloric. However, there is no cardiovascular risk with this medication in particular. And with the reauthorization criteria, we just want to make sure that there's, again, a positive clinical response when using this medication. And so with that, we have our dosage and quantity limits, and then our pen form. Okay, and so this pen form is again to help facilitate the prior authorization process. And with that, I'll give the committee some time to review and ask any questions.
Thanks, Ryan. Committee members, any questions? So it doesn't look like we have any stakeholders for gout agents.
This is Lita, there's no.
Sorry.
This is Lita, there's no other stakeholders.
And I hear a question.
So sorry, this is Leah. Could we just scroll down so we could see the rest of the form? Thank you so much.
Any need for more time or any questions? Let's go ahead, if Marissa, and bring up the motion. And when the committee's ready, go ahead and consider that.
This is Diane Schwolke, and I move that the Apple Health Medicaid program implement the clinical criteria listed on policy 68.00.00-1 as recommended.
This is Ginny Bucola, and I go ahead and second that motion. And I'd like to ask all in favor.
Aye.
Aye.
And if there are any opposed? And the motion carries. And we'll move to the last policy for the day, the tyrosine kinase inhibitors with Ryan. Thanks, Ryan.
All right, and looks like Marissa has it pulled up. This is Ryan Takatomo again. And so this policy is specific for the oral tyrosine kinase inhibitors. The purpose of this policy is to provide blanket criteria, not necessarily criteria specific to a drug or its indication, but to ensure that appropriate documentation is captured to support the clinical use of these agents. And so we have our list of all the agents. Some stakeholders have brought to attention that some oral TKIs or tyrosine kinase inhibitors are missing. So after this, we do plan to go back and review the list of oral TKIs and add them if they are missing. Okay, so moving to the criteria. Again, this is sort of a blanket policy, and we want to make sure we capture clinical pieces of information just to support appropriate use of these drugs. These include an appropriate indication recognized by compendia or NCCN guidelines for oncology agents specifically. We also want to make sure that we're capturing appropriate tests. So if a drug is specific for a particular genotype, then we would want to collect that information as well. We also want to make sure that the medication is prescribed by or at least in consultation with a specialist who can treat the requested medication and its indication. Okay, and so for the reauthorization criteria, essentially, we just want to ensure that that the patient or client is tolerating the medication well, that there is a documented positive response, that the medication is working, either it's keeping the disease stable or making their condition better, and that it's continued to be used for in combination if it's part of like a regimen to be used appropriately. And so with that, we have, again, our dosage and quantity limits, and then the pen form, which will be used to help facilitate the prior authorization process. And again, for the dosing and limitation section, we do recognize that there are some oral TKIs that are not included, and that we will be going back to review that list and add them if they're missing. So with that, I'll give some time for the committee to review the pen form and the policy and open it up for questions.
Thanks again, Ryan. Any questions from the committee members for Ryan? I thought I might have heard a question. Okay. Doesn't look like we have any stakeholders, so if the committee feels ready to entertain the motion, we could go ahead and bring that up.
This is Nancy Lee. I move that the Apple Health Medicaid program implement the clinical criteria listed on policy 21.53.40-1 as recommended.
All those in favor?
Aye.
Aye.
And any opposed? And the motion carries. And that completes our work for today. So the DUR board is adjourned. I hope everybody stays safe and healthy and as happy as can be under the circumstances until October. And I'll turn it over to Lita in case there are any last minute announcements.
Hi, this is Lita. Thank you, Ginny. Did a great job. Thank you all the presenters, and we'll see you guys in October.
Great. Thank you so much, Lita.
Thank you.
Thanks, everyone.
Have a great day, everyone.
Goodbye, everyone.
Bye.
Bye.